thank you everyone for joining us today. I, Amit Saxena, along with my teammates from Jagsonpal Medical Services, Dr. Deepika Chabra, are delighted to welcome you all to today's academic sessions on challenges of NCD by esteemed experts. Today's discussions are brought to you by Jagsonpal Pharmaceuticals Ltd, makers of LycoRed, the first lycopene brand launched in India, having lycomato with zinc and selenium. When oxidative stress threatens, LycoRed offers protection at cellular level. Backed by more than 35 clinical trials and 55 publications, LycoRed is the most potent scavengers available in India. A warm and hearty welcome to esteemed experts and attendees. Dear attendees, we request you to post your questions, suggestions, and clarifications by text in Q&A box. Please note this webinar is streaming live on Facebook. The link has already been shared on the chat box. To refer this webinar in future, please visit our YouTube channel, Jagsonpal Medical Insights. As we initiate today's session, I request Coordinator Dr. Maninder Ahuja to kindly initiate the program.
Good evening, and thank you, Jagsonpal Pharma, for being our technical collaborator. I think today's webinar is the collaborative effort of. Am I audible?
Yes, ma'am. Yes, ma'am. Audible, ma'am. Audible.
Audible, na? So, collaborative effort of Society of Meaningful Life Management, IMA Haryana chapter, and AOGD. Now, the aim of this society has always been to be the progressive and to bring out the new idea through key opinion leaders. So today we'll have a galaxy of key opinion leaders from various fields and from various age groups also, from younger to the age group. So, and we will be having discussions on very important topic of non-communicable diseases. But before I talk on that, I'll hand over the mic to my Master of Ceremonies, Dr. Divya Saxena. She is the actually director of Saxena Multispeciality Hospital and course director for RSSDIA accredited course in diabetology. She happens to be a physician and tutorship of MSc diploma course of University of South Wales, UK. She's undergoing that diploma. She has various publications in various state and national journals and many awards also, and she's very active in Haryana chapter of IMA, and I welcome her as a Master of Ceremonies, and I hand over the mic to her without wasting much time. Dr. Divya Saxena, it's all to you now to handle the ceremonies.
Thank you so much, ma'am, for the kind introduction, and a very good evening to all of you on this evening. Today, we all are here for discussing a very important subject, that is non-communicable diseases, under the super guidance of Dr. Maninder Ahuja, ma'am, who is doing a tremendous work in this field. And really, this topic needs more discussion. More we discuss this topic, more we can pass on the benefits to the society, and this needs discussion not only on the doctor's level but at the society level also. So a very good evening to all the esteemed guests of the today's evening, the learned faculty from all over India, and to all the participants from all over India who has joined us. Thank you so much for joining us. So I would rather invite Dr. Maninder Ahuja, ma'am, for the further proceedings. Ma'am is an editor of Journal of Midlife Health, JM is a PubMed journal. She has a research on age of menopause and determinants of age of menopause, which is widely quoted. She is also a co-author for Clinical Practice Guidelines of Menopause. She is an IMS publication. She has guidelines for paramedics and private practitioners. She is also a WHO paper author and editor of many books, and she has been national and international faculty in so many conferences and webinars. So, ma'am, I would invite you for the further proceedings, and the co-convener of today's program, Dr. Punita Hasija ma'am, also for inviting our chief guest and guest of honor for today's evening. Ma'am has done her PG in PGIMS Rathore. She is doing private practice at Akriti Nursing Home, Faridabad. She has been a president of IMA Haryana state for 2022. She is heading policy and research wing of BJP as well. She was first female president of IMA Faridabad, and she has so many accolades and awards to her name. To over to Maninder ma'am for the further proceedings and for inviting the chief guest of today's evening.
Good evening, everybody. All the glittering faculty who's there, all the chairpersons and all the audience and delegates from various countries, and our chairpersons also from South Asian countries of Bangladesh and Pakistan also. And it's my privilege, honor, and I'm so glad to be introducing none other than our incoming president, who is the president-elect of FOGSI, Dr. Hrishikesh Pai. Now, FOGSI is a strong international national organization of 37,000 trained gynecologists, and this is the largest body in the world. And Dr. Hrishikesh Pai is a very, very progressive leader, and he has been at the helm of affairs of many other organizations also. But the main thing is they are medical director of Bloom IVF group of chains, which is there all over country. And area of interest are, of course, the corporate affairs, IFFS, International Federation of Fertility Societies, postgraduate teacher in the gynecology and DNB examination, visiting professor in obstetrics and gynecology, Manipal University, India. And major achievements are he has been awarded with so many fellowships of RCOG, Obstetrician and Gynecologist, London, UK, past Secretary General and Senior Vice President and Deputy Secretary General, Treasurer, Chairman, FOGSI, past President, ISAR, IAG, MOX, and so many honors and awards. If I'll go on talking, then I think we won't be able to give justice to other speakers. So to you, Dr. Hrishikesh Pai.
Thank you, Dr. Maninder. I would like to first of all recognize that the Society for Meaningful Life, of which you are the president, and the Haryana IMA as well. Dr. Punita Hasija is the president, and Dr. Rathore, who is our AOGD president. You know, Delhi Society, incidentally, AOGD is now the largest society of the federation. You know, Bombay Society got bifurcated into Thana Society and Navi Mumbai Society. So now it is no longer the largest society, which is so that privilege goes to the North India AOGD Society. So, you know, it's a very important society of the federation. And there are a lot of other people there. Dr. Singh, who is the president of IMA, Dr. Divya Saxena, Dr. Rubena Sohel of the SAFOC president, Sudha Sharma, who is the Secretary General of IMS, Dr. Zinnat, who is the Secretary Bangladesh Menopause Society. Then we have the, can you hear me, Maninder?
Yes, of course.
Yeah. Then Dr. Bansal, Dr. Piyush Ranjan, Dr. Gupta, Dr. Pandey, and our own Anita Rajoria, who is also, I think, chairman of the adolescent committee of the AOGD. And one day, hopefully, will also become chairman of the FOGSI as well in the future to come. And I can see Dr. Deepika Chhabra as well. So I would like to say that, you know, I would like to point out to you that the NH National Family Health Survey number 5 is very interesting. You should read it. So the first survey was carried out in 91, 92. Now this is the last survey which was carried out in 2019 and 21. And so, you know, I will not skip everything, but just to focus on the NCDs, because NCD means cancer, diabetes, cardiovascular disease, and stroke. But I would also like to add some additional thing like anemia to it, but that is debatable. But anemia is a subject by itself. So if in 15-16, the anemia incidence was 53%. So the National Health Survey number 5 has covered 6 lakh and odd households, and they have surveyed 7 lakh women and more than 1 lakh men. and it was carried out by 17 field agencies. It was statistically analyzed, and they have found that there is a slightly increase in the incidence of anemia from 15-16 to 19-21. 53% has gone to 57%. The hypertension incidence, that is systolic more than 140 or diastolic more than 90, or patients who are taking antihypertensive medicine, that is the classification that they took, that for the first time this survey has analyzed what is the incidence of hypertension, and that is nearly 21% in the population. The blood sugar, which is more than 140, or people who are taking anti-diabetic treatment, for the first time they have found out 14% is the incidence of high blood sugar. And interestingly, BMI, body mass index, less than 18.5, means thin individuals. In 15-16, it was 22.9, that has gone to 18.7. So there's a drop in the thin individual. More and more people are having access to food in our country. And the BMI more than 25, that has also increased from 20%, it has gone to 24%. So, and the final statistic I would like to show you is the waist-hip ratio in female, that is more than 0.85. It was first time it has been calculated in our country this time in the survey, and the incidence is 56%. So obesity, which also I consider as a NCD, the incidence is nearly 56% in women. If you look at the based on the calculation of the waist to hip ratio of more than 0.85. So these are all parameters. So our population is improving in its character, and only barring anemia, where there's an increase in the incidence. Maybe there's a bias in it, but we don't know. But rest of the NCDs are increasing. So we are becoming more and more westernized as we are going along. And so this becomes a very important aspect. So the mortality rate contribution slowly will be coming from these non-communicable disease areas, which are becoming more and more prominent in our country as we become more and more prosperous. And this there's a national program on this. As far as I am concerned, the government has already got the national program and the 15th Finance Commission, which is the where they earmark funding from 2021 to 2025-26. Funding has been 16,000 crores have been allotted by the government to the rural areas, and 2,000 crores to the primary health centers in the urban areas. And just one more final statistic is that the NCD clinics have been started in 682 districts. 191 district cardiac units have been started. 5,408 community health centers have been started. And there's a lot of ASHA workers, etc., who have been trained in this whole area. As far as I am concerned, as FOGSI president, the strategy for the future, because I have got 6 pillars of implementation of policy, in which academics is just one of the 6 pillars. One of the important pillars is the CSR. We have got 11 CSR initiatives which I'll be implementing in my year. Of that, the NCD is the main initiative, and my program is called Badlav. So just like Dr. Shanta Kumari's program is called Dhira, that is violence against women, my program, the CSR program which I'll be launching, it's called Badlav, and it is mainly focused on the NCDs. And in this, the whole program structure is that we'll be taking volunteer clinics. I'm expecting about 1,500 volunteer clinics from all over the country. And just like when during my Secretary General tenure in 2016, along with the IMA, we had launched and the Government of India, we had launched the Pradhan Mantri Surakshit Matruttva Abhiyan. If you go to the site, my photo is there on the site. So similarly, I'm launching the Badlav program, which will be on 18th of every month. All the volunteers of the Federation will, in their clinics, do free checkup on blood pressure, glycosylated hemoglobin, etc., etc. They'll do the parameters, they'll do the data entry, they'll do the examination. And 18th of every month, we'll have a free checkup. We'll collect the data, analyze it, look at how, and we can also give about 30% discount in our investigations as well as the treatment. So this is the main policy thrust that I would like to see FOGSI doing in my year as president. I would like to thank you, and I'm really interested, looking forward to listening to your conversation, and wish you all the very best for this program. Thank you.
Thank you, Dr. Hrishikesh Pai. And it's very heartening to see that FOGSI is going to do in long way, I think, in prevention of non-communicable diseases, because if we can really work on that, practically it can be implemented, that it can have the lots of impact on the future health of population of India. So, Dr. Divya, I just welcome to Dr. Asmita Rathore, who is heading now, as the Dr. Hrishikesh Pai has already highlighted, that AOGD is now the largest society of FOGSI. So because previously it was considered the Bombay, but Bombay has been divided into two societies. So AOGD is the largest body. So we have around 7,000 members in AOGD who can collectively, I think, shape the future of women's health also. And she is the director, professor, and head of obstetrics gynae, Maulana Azad Medical College. And area of interest are maternal fetal medicine, vaginal surgery, program coordinator, fellowship in National Board Maternal Fetal Medicine, more than 50 publication in India Journal, joint editor of 4 books, and then more than 25 chapters in various books, investigator for many national and international research projects, and professional bodies and office bearers of AOGD, Joint Secretary. She was previously then Secretary, then RCOG, North Zone members and representative, and expert member task force, maternal health, and then National Health Authority, UPSC, MCI, and BICMR. So to summarize, she is a very, very active person, not only academically, but also on the social fronts and on the professional organization front also. It's really honor, Dr. Asmita, to have you here, and we would like to have a few words from you, key opinion leader, a wisdom words from you regarding how to control the non-communicable diseases in our country.
Thank you so much for those kind words, Dr. Maninder. At the outset, I would like to congratulate Society of Meaningful Life Management and IMA Haryana chapter for organizing this wonderful webinar on a very important topic of non-communicable diseases. We all know, with increasing life expectancy and urbanization, as Dr. Hrishikesh Pai elaborated based on an NFHS data, that the problem of non-communicable diseases is going to increase, and we need an all-out approach to really deal with it. As far as AOGD is concerned, midlife management and midlife clinics remain the key portion of taking care of women's health. And I think that's a very, very critical area where we need to focus on in future. The today's scientific program is extremely well designed. A learned faculty, including Dr. Maninder Ahuja, Dr. Pandey, Dr. Gupta, Dr. Bansal, Dr. Piyush Ranjan, are going to deal with very, very important aspects of how to prevent the non-communicable disease. And I'm sure the expert opinions of the chairpersons, national and international faculty, and the other experts in those areas are going to educate us on that topic. And I'm sure this not only will upgrade the knowledge of our participants today, but also stimulate all of us to move further and become active on this front. How we train ourselves to deal with non-communicable diseases, how we educate community about the non-communicable diseases and its prevention. Thank you, Dr. Maninder, and all the best for this webinar. I'm sure it's going to be great under your leadership. Thank you so much.
Thank you, Dr. Asmita, for those kind and very words of wisdom that we have. We are doing a little work on the midlife clinics, but that is where please stay till the end, because we'll be making a few let's have the new thought processes. The purpose of all these webinars is always to create a new thought process, because change is the constant thing which is happening in the science and in our bodies and in our lives.
Just would like to point out that we have a lot of infrastructure. So we need to see that we don't duplicate infrastructure and, use the present infrastructure in a very efficient, and more funding should be given to the pre-existing infrastructure. What happens in our country now, all the time new things are started and they are not sustained. Many of the primary health centers are in dilapidated condition. Many of the general hospitals don't have facilities and equipment. So we need to, what is the present infrastructure? We need to improve the quality of that infrastructure and upgrade those things. We have enough number of people who can implement. So this is my request. So when you discuss it, Miss, what you had also discussed with me about midlife clinic, the clinics are already there. What we need is to do advocacy, get them to access those clinics and give facilities in the pre-existing clinics. That will be better. So this is my request to all of you. Thank you.
Dr. Hrishikesh, exactly that is what we will be discussing, how to strengthen the already existing infrastructure, because no way we can create the new infrastructure. The same existing infrastructure has to be utilized as we go along in our discussion. But we have among us our President IMA, Dr. Sahajanand, Prasad Singh, who is the National President, Indian Medical Association, and we know how many members of the we are in the IMA, is the strongest body of the country representing all the specialities. He was the organizing secretary of IMA NetCon 2021, Registrar Bihar Council of Medical Registration, member National Medical Commission, medical superintendent ESI Hospital, Fulwari Sharif. So he has progressed in a stepwise manner from his education to the employments and then coming to the prestigious post of President of the Indian Medical Association. And he has been member of Red Cross Society and President Lions Club. So that means he has the one multifaceted personality who has worked in all the areas, starting from the social to the NGOs level and the professional bodies also. Dr. Sahajanand, today, welcome to this webinar of key opinion leaders on non-communicable diseases, how we have to move ahead so that we can overcome to some extent or reduce the intensity or the extent of the non-communicable diseases. Over to you, Dr. Sahajanand.
Thank you, madam. Thank you, Ravina, Dr. Saxena, Dr. Punita, Dr. Rathore, Dr. Maninder, and others ladies who is present here. So non-communicable disease is very important topics we have chosen. So we are only focusing the only communicable disease by the antibiotic and other things we have achieved. But non-communicable disease like diabetes, hypertension, cancer, and strokes, these are the main problematic disease. So our country, mainly India, is suffered from this diabetes and hypertension. So we are not focusing. So we have to be alert. Especially doctors are suffering diabetes and hypertension and sometimes cancer also. So we are treating properly communicable disease, but non-communicable disease, we are not neglected. So we have to focus on non-communicable diseases. So for that, we have to alert, we have to do the exercise, and to those who are smoking, they should not smoke, and they should not take alcohol, and regular walking. Those who are taking that hypertension, diabetes will not be occur for the doctors only. So for the poorest people and for the educated people also, this diabetes and hypertension is very much occur. We are seeing the practice. So thank you very much. You are calling. So we are here, and I have to go somewhere. Just Saxena has told me. So thank you very much, madam. We have to alert for the communicable disease. We are very much anxiety that many persons are suffering from diabetes and hypertension. So hypertension clinic should be all the doctors especially. So take this blood pressure, diabetes, for diabetes, blood sugar, fasting into our optional foods. So we have to care for himself and ourselves also. Thank you very much. Thank you, madam. Thank you.
Thank you for joining.
Sahajanand for kind words, and I'll now request Dr. Punita Hasija, who is the co-convener for this, to say a few words, and then to Dr. Divya for the further introduction of all the chairperson. Dr. Sahajanand, I just wanted to ask you one question. We can strengthen our private practitioner by giving them guidelines that each and every practitioner who is just looking at the patients of fever or diarrhea or anything, they can at the same time, a simple measurements of height, weight, BMI can be done. And the pharma companies who are giving any drugs or something, they can give those BMI calculating disc. So if we can just have those things, and a simple 2 minutes consultation will go in, I think, a long way to create an awareness about these non-communicable diseases. Because the first step has to be awareness of the public and the doctors, and then second step, how to implement it.
You are right, madam. We have to alert and we have to do something for the public and for himself also. So that should be see in the clinic, BMR or all. There is a provision of taking blood pressure, quick blood sugar. So in the OPD, you can easily diagnose the cases of hypertension and this diabetes. You are saying correct, madam. We have to follow. So, thank you.
Dr. Punita. Dr. Divya Saxena, please introduce. You have introduced Dr. Punita Hasija. Dr. Punita, please say a few words.
Yes, good evening, everyone. Good evening, Sahajanand sir, dear esteemed faculty, Dr. Maninder Ahuja ma'am, and Dr. Hrishikesh Pai, and all my seniors and my colleagues. I think Dr. Pai, Dr. Sahajanand sir, and ma'am, Dr. Rathore ma'am, they have already explained the need of taking care of this non-communicable diseases. We definitely need to be alert on this because our country is becoming the capital of non-communicable diseases. So I think very simple ways to how to check the blood pressure and the routine sugar level checking and routine lifestyle modification to each and every patient we should give. And I think by just simpler steps, we can very well diagnose hypertension and diabetes, and we don't need any hi-fi things for these. And in case if we find some population who is at risk, we can refer them to a specialist for a better management, and we should not cling to that patient कि patient हमारे से treatment कराता रहे. ऐसा नहीं करना. We have to be very, very careful because nowadays we have seen that even the 25-year-old person, they are getting this MI and all. So we need to be very, very careful regarding non-communicable diseases. And we are, I think we are very, very good faculty with us, and we will be enlightened by them on this topic. And over to you, Dr. Maninder Ahuja ma'am. And really a good topic you have chosen for this session. And you have a galaxy of speakers, and all are excellent in their field, ma'am. Welcome everyone from IMA Haryana side also. Thank you, ma'am.
Thank you all the honorable guests of the evening for enlightening us. And really the key of decreasing the disease burden from everywhere, from all over the world, is to spread the awareness. And we are here to spread the awareness today. So we have eminent speakers among us. So heading towards a scientific session, I would like to invite the chairpersons of the scientific session. First of all, I would like to invite Professor Rubina Suhail, who is a consultant of St. Gynae Hamid Latif Hospital, Lahore. She is a champion of sexual and reproductive health and rights. She is pioneer of kangaroo mother care in Pakistan. She is chair FIGO Committee on Women Facing Crisis, past president of SAFOG also. She has so many publications in her name, including IJOG and the Lancet author of books and chapters. She has written an upcoming book on Handbook of Midwives, and she has been awarded with Young Gynecologist Award by AOFOG in 1995. And coming to other chairpersons, that is Professor S.K. Jeenat Ara Nasreen. He is a professor and head of the department of S.K. Seeker Women's Medical College and Hospital. She is chairperson, scientific committee, OGSB. She is a secretary general of BMS Bangladesh Menopause Society. She is member secretary of CPT committee of BCPS. She is secretary general of RCOG of Polycystic Club of Bangladesh and Osteoporosis Task Force of Bangladesh. She has been organizing secretary of Bangladesh Perinatal Society. She is editor-in-chief, journal of J.H. Sikdar Medical College and Hospital, and so many other accolades to her name. And coming to another chairperson, who is Dr. Sudha Sharma. She is a former professor, PG Department of Obs and Gynae, GMC Jammu and Jammu Kashmir. She has been Secretary General IMS, Honorary Professor IMA. She is a managing committee member of PCOS Society of India. She has been a founder president, Jammu Menopause Society. She is an editor-in-chief, Journal of Midlife Health, and member editorial board of Journal of Support. She's been editor in journal JK Science, Journal of Medical Education and Research, and so many long list of positive things and accolades to her name. Now, coming to the last chairperson of this scientific session, Dr. Anita Rajoria, who is head of the department of and the senior consultant of Hardigar Arogya Sansthan, Government of NCD of Delhi. She has present affiliations with Asia and Oceania Federation of Obstetricians and Gynecologists and Obstetrician and Gynecologists of India. She has so many achievements to her name. She has been a founder, Vice President, Delhi Gynae Forum. She has been past chairperson, Reproductive Endocrinological Committee, AOGD. She has so many awards also to her name. APJ Abdul Kalam Achievers Award and Appreciation, DMA Shiksha Ratan Award, Human Championship Women Achiever Award, ISAR Champion of Women's Health Award, and so many other. She has many publications in various journals, national and international. So over to the chairperson of the scientific session for the further proceedings.
Thank you for the nice introduction of all of us. So I think we can proceed to the academic session. And the first presentation will be by none other than Professor Maninder Ahuja ma'am. She is rightly introduced, and she's a very active member of all the various societies, and she's a true leader in each and every way. Currently, she is the President, Society of Meaningful Life Management, and is the convener of the current webinar we are attending. She's a very thought-provoking leader. She is a motivator. Currently, she is the director of Ahuja Healthcare Dental and Infertility Center. She has worked tremendously in various aspects of women's health, like adolescent, right from adolescent to menopause. She has been SOFOM's vice president, then web in charge. She has been their secretary general. She has held various posts. And Madam has been Vice President FOGSI between 2013 to 14. And she was President Indian Menopause Society 14-15. I remember vividly that she did wonderful job during her tenure. Ma'am is currently affiliated to various professional bodies like ISAR, ISPAT, NARGI, and has been guiding force for so many of us. Madam has had various publications. Her original research, she's also conducting various projects related to non-communicable diseases. I'll request everybody to participate in that and contribute in the study. She is the editor-in-chief of JMH and national and international faculty at various conferences. And Madam has been awarded various prizes for her publications, for her social work, and other activities. So over to you, Maninder. Ma'am, I do not have words to introduce you.
Thank you, Anita, for those kind words. Today, we have a galaxy of key opinion leaders who are going to talk about the main issues of the non-communicable diseases. Dr. N.K. Pandey, Dr. Rakesh Gupta, and Dr. S.S. Bansal, and followed by a panel discussion on weight management by Piyush. I'm just going to give a quick review of the non-communicable diseases. But before that, I have to say my thanks and welcome to Jagsonpal, first of all. Then thanks to all the glittering dignitaries. I'll be just naming them again. Dr. Ashley Pai, who had just delivered a beautiful address and guided us about the way forward also. Then Dr. Sahajanand Prasad Singh, who has promised that they will be strengthening the private practitioners which are already existing under the flagship of IMA. Dr. Asmita Rathore, as president of the AOGD, has given her wise words. And Dr. Rubina Sohail, Dr. Sheikh Jinnat Nasreen, Dr. Sudha Sharma, Dr. Anita Rajoria, they are all welcome as chairpersons. and Dr. N.K. Pandey, Rakesh Gupta, S.S. Bansal as the faculty, and Piyush Ranjan from AIMS and his team Sakshi. And his team consists of Sakshi, Tanveer, Varisha, Ananda, Gopal, who are going to give us a beautiful presentation or panel on the weight reduction. The only thing that is constantly is change. So what we'll be discussing today is what changes we have to bring. And the doctor of tomorrow may not give the medication or will just tell the prescription of diet only. So what's happening in the true scenario is that we are living now in an aging world. So, but that advantage of increased life expectancy is not being translated into healthy aging. So that is the problem. When we have to increase expectancy, it should be healthy aging so that we can remain independent when traveling, or whenever when we have to put our luggage in the overheads and we don't need help, or we are not confined to the wheelchairs. So that is the functional ability which should be there. So the process of developing and maintaining the functional ability was the healthy aging, which was defined by 2010 only in the WHO. Then what's happening is the health age expectancy, which has increased by 6.6 years, but the increase in healthy aging is not there, it's just 5.4 years. So that means we have people who are living with disabilities, and the people with living disabilities are not going to make a healthy society at all. And all over the world, the persons above the age of 65 years are from 2019 to 2050 are expected to rise by about 120%. But this is not again going into healthy aging. And what is this change is occurring now more in the middle income group countries and the low income group countries, like us, because high income group countries have already seen that rise. So what we have to do is we have to maintain the functionality. Both these women are of the same age, but one is with the wiper, one with the stick. So same way we want a healthy aging or a population which has functional ability. And what is that functional ability? Meet their basic needs, learn, grow, and make decisions, be mobile, build and maintain relationships, and contribute to the society. That is very, very important, that they should be contributing to the society. So what is helping impending, or what are the challenges to the healthy aging or the non-communicable diseases? So these are the basic challenges, and which are responsible 71% of the all deaths globally. 85% of these premature deaths occur in the low and middle income countries. And out of these non-communicable diseases, 4 are very important: coronary heart disease, 17.9 million, cancer, 9.3 million, and then obesity and diabetes. So unhealthy diet, smoking, physical inactivity, excess alcohol consumption, all of us know that these are the modifiable risk factors. So what is increasing is global obesity. So that global obesity will be covered by Dr. Piyush, I think. So I will be just giving you an overview that this is the one which is responsible for most of the causes of non-communicable diseases and disabilities. But what are other causes? Musculoskeletal disorders, osteoporosis, sarcopenia, fragility. So whatever private practitioners have to know in their clinics only how to diagnose these conditions. Is there a gender bias? Yes, women are being affected more than men because of being transition in the menopause area. They have many risk factors because of the hypoestrogenism. Then they have more weight gain. They are being marginalized. They don't look after their health, and the society is still not looking after their health. And while think that the smoking is more in the men, but the women are also smoking more because the cigarette manufacturers are glamorizing smoking as a way of improving women's social and political status, and symptoms in women are different and likely to be missed. So this is what is happening. Obesity is increasing, and women healthcare should be given priority. That is very important. Age, it's occurring in all age groups, region, and countries. All they are being affected. And with older, it's not that the older age group is also only the one which is being affected, but evidence shows that more than 15 millions of all deaths attributed to non-communicable diseases occur between the ages of 30 to 69 years. So that means if we have to prevent, we have to start early. Maybe somewhere around midlife, Midlife has not been defined, but something between the 40 and 60 years is the midlife. So if we have to prevent non-communicable diseases, we have come back to the midlife. So that is why FOGSI midlife clinics actually were started when I was the chairperson of the midlife committee of FOGSI. So they have been working, but we have to change them, of course, because we are the society which is dealing with the health of women only, but non-communicable diseases are occurring in both the sexes. So perhaps we should change these clinics to healthy clinics for the midlife, where the couples will be seen as such and not just the women only. Socio-economic impact of non-communicable diseases, all the dignitaries know and all the delegates know that it reduces the agenda of sustainable goal development, that progress is hindered, then its global cost of the to public expenditure is increased about 30 trillion all over the world. And in India itself, 5 to 10% of GDP is being spent on non-communicable diseases. And at the personal level, it causes poverty. They are never able to come once they are suffering from it, because if there is a prevention, it's going to be cost effective. And if we have to treat the non-communicable diseases, it's going to increase the cost for the society, for the community, for the governments, and for the persons itself. So that's why WHO had dedicated the 2020 to 2030 as a decade of healthy aging. So during the decade of healthy aging, we have to change how we are thinking about ageism. We have to make them part, and prevention is there. Developing communities have to develop in a way that they can foster to the needs of the old people, and delivering person-centered integrated care and primary health services is important, and providing older people who need it with access to quality long care. But if we have to achieve that goal, again, we have to start in mid-40s somewhere. WHO has again highlighted, so we have to reduce the burden of all these diseases, CADs and respiratory diseases, and weight and activity has to be increased. Our challenges are there's not much awareness, huge population of midlife persons is there, few practitioners are there, heterogeneous population, and we don't have much awareness. So we have to bring that badlav. I'll stop here and now hand over to my esteemed faculty, because at the end of their talks, we will again discuss what that badlav is going to be. Sorry. So over to you, the chairpersons.
Thank you, Dr. Maninder ma'am. You have very well highlighted that we have to start somewhere. Badlav ya parivartan lana bahut hi avashyak hai. And of course, you know, the prevention of non-communicable diseases as such starts in utero. And as the age advances, adolescents are also be taken care of so that they do not become obese, they do not have early onset diabetes and all those problems. Because we understand that lifestyle changes are the ones which will make a difference in the life of all men and women. So we have to protect our future generations also. We have to protect our women, our men, and prevention and delay of metabolic syndrome and other problems of how to prevent cardiometabolic diseases. This will be, you know, taken up in the lectures which will follow. So I will request my other co-chairperson, Dr. Rubina Sohail ma'am, to kindly make a comment and introduce the next speaker, Dr. N.K. Pandey, sir.
Thank you very much. Very good afternoon to everyone. It's a very, very important topic because according to the understanding that I have is that once you reduce the maternal mortality, non-communicable disease is going to be the biggest killer of mothers in the world. So we as gynecologists and obstetricians have to play our part in prevention, diagnosis, and management of non-communicable disease. If we are able to set up well-woman clinics, screen for patients and guide them in time, I'm sure we can put a dent in this numbers of non-communicable disease, which is resulting in a lot of deaths, not only of women, but also of men. With this, I would like to have my slide for introduction of our next speaker, Mr. Pandey. I would like to introduce Dr. Narendra Pandey. He's a very well-qualified person who has had a lot of honors and awards. He is the chairman and managing director of Asia Institute of Medical Sciences in Delhi. He has received the Padma Shri Award by the President of India in recognition of distinguished services in the field of surgery way back in 2014. He has received a BC Roy National Award for the year 2005 for the development of minimal access thoracic surgery, Beta Dean Achievement Award by the Association of Surgeons of India in 2010, Doctor of Science Award being conferred by Tirthankar Mahavir University, Muradabad in 2013, Award of Honor for Commendable Academic Contribution from International College of Surgeons during the National Surgical Update in 2004, Certificate of Appreciation, and bestowed with the Distinguished Service Award by the Delhi Doctors Association in 1997, and the list goes on and on and on. So I would request Dr. Narendra Kumar Pandey to please come and give his presentation on this very important topic. Thank you very much, sir.
I must say that Dr. N.K. Pandey is the glittering star of our Faridabad area, and he has given the, I think, international presence to the Faridabad and wonder our state-of-art hospitals. All the three faculties which are there, Rakesh Gupta, Dr. Bansal, and Dr. Pandey, we are very proud of them.
Thank you. Thank you very much, Dr. Rubina Sohail, for introduction. I am just a common surgeon, so I am really privileged to be in this meeting today. And thank you, Maninder, for inviting me. I would also like to welcome Dr. Pai, Dr. Sahajanand, Prasad, Professor Asmita, Rathore, and our own Punita. Actually, I'm not going to talk about prevention. I am most unfit person to talk about prevention. There are two eminent speakers who are going to follow me up and talk about prevention. I'm going to talk something quite different. I think we are living in most exciting time of scientific development that has happened in recent time in biomedical sciences. And not many years ago, it was impossible to understand if we can decode total genetic code. Now that is available for a small fee. And also I appreciate, I'm a grandfather, so I have seen my grandchildren being born and I have lost my parents. So I understand the pain of disease and death. So it is very important that we look at these conditions in entirely different way. In 1963, President Richard Nixon declared war against cancer. And that war is still continuing.
I cannot see your slides. Slides are not moving. Are you moving your slides?
No, I have not moved the slides, so it is not moving. So just wait. So Richard Nixon declared war against cancer, and the time that we declare war against death, because death is the biggest disease. So when we are talking about NSD is part of aging, and we have to look at how aging can be stopped. So I'm going to talk literally something different than what you expected me to talk. In northern district of Germany, Greifswald, they have an aging population, and delivering healthcare is impossible, very expensive. So for last 15 years, they've been molecular mopping the whole population. So every year they mop the population. And at the molecular level, they are using 7 Tesla MRI to map the cells. And then what they want to do is to catch the disease before it happens. And now with the technology available to us, now with the science developing so far, it is just a possibility. So if you go to Mayo Clinic, they have a software which can predict breast cancer 5 years before it happens. And we doctors have to look at the whole scenario in very holistic way. I personally feel in coming time, the need for surgeons, the gynecologists is going to disappear. And we have to find alternative professions. Sounds alarming, but it is a fact. If you look at the slide processing, many of the premier institutions in USA, they do it automatically through the computer. So when you put an image of the slide, it is being compared with 7 million images of the particular kind of cell. and then they give you the diagnosis. So you don't need a pathologist. At the moment in India, if you want to go into medical college, PG education, one of the most sought after seats will be perhaps radiology. But I think the need of radiologists is going to disappear. Already so much of work is going on that you do not need a radiologist to look at the image and give you a report. And I'll just give you the example. I was walking through New York and I saw that come and get laser surgery here and your vision will be better than 20/20. So what nature has given us, we want to break through that and give you better thing. So the time has come that we look at the reversal of the disease process rather than treating the disease process. So that is what I would like to propose. So if you look at aging, what is the aging? It's a process during which a structural and functional changes accumulate in an organism as a result of passage of time. And if you look at the human lifespan, in beginning of 20th century, it was 49 years. The world population was 6.5 billion. If you look at 21st century, in Europe and North America, the average lifespan is around 80 years. And end of 21st century, this is expected to go to 160 to 180 years. And if you listen to Aubrey de Grey, who is the professor who is working at Cambridge University, he says the man can live for 1,000 years. So I'm not going into that debate with all, I have so many learned people on this talk, so I'm not entering into that debate. But think of the scenario, if the lifespan goes to 180 years, we will have 5 to 6 times of current population, close to 30-35 billion. So we have to also look at what kind of problem it will create. More than half of this population will be more than 65 years. When we talk about age and age-linked diseases, more than 1 lakh people die every day. So it is a huge disease. We don't talk of death as a disease, aging as a disease. So we have to really change our process and look at aging as a disease. And a lot of work has happened. Now we are looking at molecular, cellular level, different protein. And Aubrey de Grey has basically worked on protein. And what he has done is looked at how we can push back the aging of the protein. Because he feels that when you look at cataract, when you look at cardiac blood supply, when you look at uterus, prostate, it is all the game about aging. And he personally feels that nanotechnology is going to process to reverse the changes in protein that is happening. And given result will be that age-related surgery will grossly decrease. What happens in our blood vessel? The changes are basically a structural and mechanical property of the vascular wall. That's the age does. And it affects the elasticity and reduce arterial compliance. And as a result, you have hypertension, you have diabetes, you have end-stage renal disease. And when we are talking about it, then more or less we are talking about more than 80% of non-communicable disease. So we have to attack here and not somewhere else, not pushing the pills, really pushing the disease backward. That is what is required. And there is a lot of technology playing into this, and the converging technology that playing into it is nanoscience and nanotechnology, the biotechnology and biomedicine, advanced computing and communication. So you look at robotics, what it is. It is advanced computing and communication, how you are computing and how you are communicating. Same way as I shared with you that in 5 years' time is not too far. People are expecting that our CT scan will be capable, MRI will be capable of reporting itself. We don't require anyone to look at the film. And then cognitive science is going to come into win. It is going to be linked with cognitive neurosciences. So your computer, my computer will think like me. It is not going to do linear thinking. And then of course, by genetic engineering, we can tweak the genome and control the disease. And extending life, when we are talking about life, how it is going to be affected, it is going to be by genetic manipulation, and you people know much more than I know by if you look at diagnostics at prenatal level, that is where we can do the manipulation. Then the stem cell research is bringing fruits. Cloning is already there for us. Molecular and nanotechnology is going to play a big role. And what is at molecular level, already a lot of work is happening. With combination of two, if you want a mango in winter, perhaps on a desktop machine, like warm your food, you can produce mangoes if you have right molecular composition that you have got. And machine learning is going to really bring in the thinking process to the computer. So computer is going to be humanized by the machine learning and integrating of intuitive. Cryonics is already coming into play. It is not freezing, it is vitrification. And there are around more than 300 bodies preserved by cryonics in USA. They are waiting for time to change, technology to change, so that they can be brought to life and live a second life. One of the major research of aging is coming from Tokyo, and Professor Chinmaya Yamanaka has worked on molecule that on mouse and animal module is changing the composition of the cell. Why it is not being commercialized? Because incidence of teratoma has been found much higher than it is expected. And I think in times to come, another 2-3 years time, this drug may be available where you can really, taking by the capsule, you can change the age of your cell. So your cells is going to bring back elasticity, is going to bring back better vision. You are going to look younger, your hairs are going to be better. So magic bullet waiting to be introduced. Already we are using a lot of drugs. We are using rapamycin, metformin, melatonin, drugs to increase the sensitivity. And these are all drugs that extend life. If you look at, if you go to Brazil, people are not worried about having cosmetic surgery. They want to look younger. If people can use Viagra, and we can give Ritalin to 4 million students in USA, then why not to use drugs to control the age, not the disease? How the AI is going to help is basically what I have said here. And what is going to happen in next 5 years, you go to the bottom of the second group, there we are going to have zero protectors and biomarkers of aging. So we can control age and aging. In next 10 years, we are going to have our brain information going to computer. We can upgrade the net. We can perhaps connect ourselves with the net. And we can perhaps have development of miniature robo, so they can go and do the needful in the body rather than be operating. And perhaps the scientist will be in full control of genome. We do not, and the genome sequencing will become much available and cheaply available. In next 20 years, it is expected that humanity and artificial intelligence is going to merge together, and where we are talking about indefinite life extension. At that time, perhaps we can download or upload information in our brain, and perhaps we will be in full control of biology. And this is not fiction. In India, 2 IITs are working on that. Perhaps many of us are not aware. IIT Kanpur and IIT Delhi have already got a working cell on how brain can be integrated with the computer. And Government of India 14 years ago created an institute for research very close to Delhi in city suburb called Manesar. It is not a clinical institute, it's just a research institute where the work basically goes integration of brain, cognizance, and how we can integrate it with the machine. So that's what is practically happening even in India. And basically, where the therapeutic intervention will come in atherosclerosis, neurodegeneration, which is a huge disease burden, cancer, diabetes, and cardiovascular process that we have been talking about. And we will look at reversal of all these processes rather than treatment. What are the current enhancement technology that is available to us? In psychopharmacology, we can alter the brain status and mood. So Prozac is available. Ritalin is available to increase the intelligence. Provil is available. Viagra is available. Other pharmacological agents, we have growth hormone. As I said, sildenafil citrate is there. Erythropoietin is there. Steroid is being used. Cosmetic surgery widely available. Pre-implantation genetic diagnosis of diseases is already available. Gene therapy is being used in number of experimental treatment. However, it is illegal in some of the European countries and USA. And cybernetic is going to be available already. I have worked at Reading University, and they have a special research wing where they are working on how alteration of mental or physical function can be done by embedding computers to the body. So that is what is being happening. Nanotechnology. Backwards. Nano devices are going to be available in next 10 years, and radical extension of life, where we are talking that you can live up to 20 years, 150 years, is going to come by combination of technique enabling human life span. This possibility is being debated among the scientific world and likely to happen in next 25-30 years. However, I thought that what are the people think is what I have quoted this from London Times, where they have projected the possibility. 22, 25, they feel that surgery can be totally done by robots. We will have artificial eyes, we will have self-driving car, which is already available. We will have hydrogen-based fuel station, which is in process. We perhaps we have mind swipes to remove the bad memory, and we have a sensory internet. So when you see a beautiful picture of garden, you can also have a smell, or you can also enjoy in other way. Just give me a second. I'm on the last slide. So in 2030, 35, it is expected that robo will take care of young children. So we get away from ayahs and servants. We will have virtual holiday. Perhaps we can have ladder in the space, artificial bacteria, perhaps self-repairing road, and virtual reality window. 35, 40, 35, 50, perhaps factory in the space. Wallpaper that plays videos, man on the Mars, country entirely used as prison. And 250 beyond, it is expected that we will have brain transplant, we will have artificial brain, we will have downloading of memories, we will get away from passport and IDs, and we will have global ID, election and taxes. We will have robotic policemen, mining asteroids, and clothing that monitors that has already come. However, I have rushed this presentation because the time was limited, but I think the best way to predict the future perhaps is to create it. And all of us have to think differently rather than treating. Is the prevention will be the key. How we prevent, whether we bring molecular biology, molecular engineering, biotech, nanotechnology, that is for future to see. But if you look at the growth of medicine that has happened, it is not going to be stopped, and we are going to be where what I am projecting you to be. And I would like to leave with a quote in Sanskrit that the earth is for people who have a strength. So in the end, the people who commit and work harder, they are going to create the new world, and new world will be without aging, without disease, and life will be unlimited. Thank you very much for listening to me.
Thank you, sir, for carrying us through that
Anita,
Yes, sir.
Dr. Sudha Sharma. She has
Thank-
she would like
Yeah.
to make some comments.
Yeah. Thank you, sir, for carrying us through that science odyssey, which future has in store for us. I like Sudha Sharma ma'am and Rubina ma'am to make comments, please. Sudha Sharma ma'am has to go, so she can comment first.
Thank you. Thank you very much, Dr. Pandey. You know, it was very, very informative deliberation. You have really thought out of the box and you have really thought very, very different. I just like, you know, those lines wherein you said that NSD is a part of aging and how aging can be slowed. We have to look into that. And, you know, you have put all the stresses on that. So we need to know the risk assessments. Once we know what is the risk of the disease, so we can prevent it at that level. So reversal of the disease process, you have, you know, given insight about that. And then at the molecular, cellular and different protein levels, you have highlighted what is at 20 years, what is at 40 years, and what is decoding. So that was very, very special part. And we all are waiting for those magic bullets which are to be introduced, and we all are waiting for those times when we are going to look younger than what we are at this point of the life. And then, you know, talked about gene therapy and your future plans and strategies were, you know, commendable. So it was a very, very, you know, interesting and informative presentation. Thank you so much. And thank you, Dr. Maninder, you know, for bringing all of us together on this platform and choosing such an important topic. Thank you so much.
Thank you.
Thank you, Sudha ma'am. Over to Rubina ma'am, please.
Yeah, thank you very much, Dr. Pandey. It was an excellent presentation, and I think a very good way to open the discussion on NCDs. It had innovative ideas, and actually the presentation is a proof of your worthiness, because as Maninder said, that you are the pride of Faridabad and that you proved in your presentation. Thank you very much. I
wish you all the best. Thank you.
I really enjoyed it. Thank you very much.
Dr. Pandey, that was my favorite topic, artificial intelligence, the future in the medicine. So even my presentation, I have given the choices whether in the future we should use the existing clinics or artificial intelligence or create new midlife clinics. So that was very, very informative. The only thing, we can compress the morbidities. Future, we should try to compress the morbidities, but to live forever will be a nightmare, I think.
Maninder, as I said, already your longevity has increased from 40 odd years to 80 years.
Yes.
That has happened in 100 years. And it has happened with whatever research has happened. The pace of research has accelerated. We are moving in different spheres altogether. So if you interact with Aubrey de Grey, who works at Cambridge, he will say that those who are 60, they will live for 1,000 years. But I think I won't like 1,000 years. But anyway, the point is not that. Point is all about extending your life disease-free and reversing your aging process. So I don't talk about treatment, I'm talking about reversing the disease process.
Yes.
And I think it is very important point that you have raised, and it brings us to the fact for lay people that it is also the reason that you should take care of your health. So if you want to live longer, there is this reason that if you are living longer, you have to be healthy. Otherwise, there's no point in living longer. So I think that it is a very interesting idea, and even without the artificial intelligence, the point of view that you need to create in the general public is that they need to live longer, and if they want to live longer, they have to be healthier. Otherwise, there's no point in being there.
And thank you, sir, for introducing to.
I would like to come to you for 1 minute, ma'am. Already 4 companies in USA, they have raised billions of dollars for Magic Bullet. So Magic Bullet is going to be sought any time. Maybe it will take 2 years, maybe it will take 3 years, but that bullet is there. It is in progress. They are only putting the safety perspective to that.
That's what I was saying, that we Indians are waiting for that.
Yeah, sir. Thank you for introducing us to new terms like cybernetics and all that. Thank you, sir. these are the areas which need exploration further. So I will request now Zeenat ma'am to make, if she has to make any comment about it, and she can introduce the next speaker.
Thank you very much. Greetings from Bangladesh. Well, actually, I am today overwhelmed with the wonderful talk from each and every speaker. So I really appreciate Dr. Maninder Ahuja to choose such a beautiful and time-demanding global burning issues, that is the challenges of the NCD. Well, it is everywhere we know that NCD is causing the most death and disabilities. And in world, we can see that it's more than 50% global disease burden. But what happened to us in Pakistan, Nepal, Bangladesh, India? It is causing, responsible for more than 80% of the global disease burden. So this is high time. And for last couple of years, 2.5 years, the corona pandemic thrown us into such a turmoil that we couldn't look at, we couldn't take attention to this NCD. So it is a high time now. And of course, Dr. N.K. Pandey has introduced such a wonderful, and I didn't know that before. So we are really waiting for that. With this, I'd like to introduce my next speaker, please. The slide, please.
CV, please.
Well, Dr. Rakesh Gupta, he is a very renowned and academician. He has done his MBBS, PGMS, and sorry, so small for me to read out. Anyway, he's the senior consultant and physician at Sahajanand Hospital sector in Faridabad. He's a teacher of DNB, emergency medicine and internal medicine. His special interest is on diabetes. That is the most important NCD. He has a lot of fellowships and he has got the memberships. He is the fellow of Indian Academy of Clinical Medicine, fellow of Indian College of Physicians, that is FICP. He is the founder secretary at API chapter of Faridabad. He's the past president, he's the past vice chairman of RSSDI Delhi chapter. He's the past chairman, IMA Hospital, a board of Haryana chapter, and secretary API Haryana state. He's really a great academician. So may I welcome Dr. Rakesh Gupta for your presentation.
Dr. Zinnat, the main thing is that we have here just 3 corporate heads. Dr. N.K. Pandey is heading the Asian Institute of Medical Sciences, and Dr. Rakesh Gupta, who has been a very close, dear friend for years together, is heading the Sarvodaya group of hospitals, and Dr. S.S. Bansal is heading the S.S. Bansal Hospital, the chief name in cardiology in Faridabad. So welcome to Rakesh Gupta. You're muted. Rakesh, Dr. Rakesh, you're muted.
What will we do?
Yeah, good evening. Can I have my slides, please?
I have to share your screen.
Very, very warm good evening to all the esteemed panelists, my senior Dr. N.K. Pandey, my fellow colleague Dr. Bansal, all the senior eminent panelists as chairpersons. And I must thank Dr. Maninder Ahuja for inviting me to this particular session. I'm really amazed to listen to the talk of Dr. N.K. Pandey. It takes me to my childhood, where we used to read stories and fictions of space and everything around, which has become reality today. If my granddaughter today listens to the talk of Dr. N.K. Pandey, by the time she becomes an adult, she will be realizing everything around him to be very, very real. He has taken us to an exciting journey into the space, into the future, which I'm very sure is going to become realistic very soon and very fast. That I'm very sure. So after that exciting talk of Dr. N.K. Pandey, let us come back to the reality around us, which we see in our day-to-day life. I'll be speaking a little bit about the diabetes as to how to diagnose it early and how to prevent it. So diabetes is a mild disease, but has got a serious consequences. Today, we are living in a world where NCD is all around us, more so too with the diabetes. In fact, diabetes is a soil on which all the NCD develops and grows, like coronary disease, like hypertension, like strokes, and everything around us develops on the fertile soil of diabetes. Diabetes is the basic metabolic disease which leads to the progression of all the fellow sisters and brothers which it has around us. So let's have a look at the magnitude of diabetes. See, globally, 1 in 10 adults have diabetes. The age of 20 to 79 years, almost 537 million people across the globe do have diabetes. Next, please. I'm not having control on my slides, Maninder.
You had to ask me again, I think.
Yeah, sure. I have asked. Kindly give me control so that I can control it.
Now I have approved.
Sure. Thank you. Let me see if I can. I'm sorry for the interruption.
It's okay.
It is still not happening.
You're getting? Yeah. Yes.
Yeah.
You are
now
moving.
it is.
Yeah. Yes. No.
So I was telling you that 1 in 10 adults globally has diabetes. That approximately 537 million people across the globe are having diabetes. Out of these, 1 in 2 in adults is yet undiagnosed. The total volume around 140 million people across the globe. 1 in 9, that is 541 million people, have got impaired glucose tolerance, the early stage of diabetes or the pre-diabetes, what we call as. 1 in 18 adults has got impaired fasting glucose, that approximately 120 million people across the globe. 1 in 6 live births across the globe are affected by hyperglycemia in pregnancy. 80% of those have mothers with GDM. That means GDM is a very, very strong factor in these factors. 1.2 million children and adolescents below 20 years have type 1 diabetes, although it's less common. 95% of the diabetes belongs to the type 2 category or the other categories. Unfortunately, 3 out of these 4 people with diabetes, they live in low and middle income countries from where we come. And India, we have more than 7 crores as diabetics. We have practically become the diabetes capital of the world. Now we want to become the diabetes care capital of the world, and hence we try to control the diabetes, prevent diabetes, take care of the diabetes, and try to prevent complications. I'm sorry, this is not what. Yes. Now, to prevent the diabetes from occurring, so we have to screen the population. Then how do we screen it? But before we go on to the screening, let's have a look at the natural history of diabetes. See, diabetes happens. Can I have the slide back, please? I'm not having good control. I'm sorry, Maninderji. I'm so sorry. Yes. So this is the natural history of diabetes. We start with a normal individual, which has an early stage as pre-diabetes. Then we have a clinical diabetes, and then we have complications of diabetes where there is a target organ damage in the form of retinopathy, neuropathy, nephropathy, and then the major cardiovascular disease, and then stroke. So this is how the diabetes progresses. It is a progressive disease. So by virtue of these things, diabetes 2 diabetes is an ideal candidate for screening and prevention, as it has a very well-defined preclinical stage in the form of impaired glucose tolerance or an impaired fasting glucose stage. Even early clinical stages are silent. Early diagnosis can prevent complications, which I have just enumerated. Early initiation of treatment can prevent complications from happening, and effective treatments are available. So that makes the diabetes an ideal candidate for screening. We have looked at the ADA criteria. ADA is American Diabetes Association, which has laid down the criteria for testing for diabetes in asymptomatic individuals which are undiagnosed. People of the age of more than 45 years of age should be tested, and if normal, should be repeated after 3 years. Testing should be considered at a younger age or to be carried out more frequently in high-risk individuals. For example, those are obese, having more than 120% of the ideal body weight, who have first-degree relatives with diabetes, have strong family history, who are members of the high-risk ethnic groups. For example, we as Asian Indians. If a lady has delivered a baby weighing more than 4.5 kg or 9 pounds, or have been diagnosed with the GDM, people who have got HDL cholesterol as low as less than 35, or who have got EG of more than 250 milligram per deciliter, or who have on a previous testing had IGT or IFG. So these people should be screened for presence of diabetes. My next slide, please. Can somebody make it next?
No, I'll just tell me when next. Just tell me.
Next. Okay. The ADA recommendations are not practical for India, since all the Indians fall in a very high-risk ethnic group. So there's no cost-effective way to screen the entire population. It is very difficult to screen 138 billion of population. So now let's have a look. Is there a way of narrowing down our research? Then there's a need for an urgent need of mass screening programs. It is very difficult and expensive to do universal screening, and hence we do need to do a selective screening to make the screening most cost-effective. The question is how to make the cost-effective screening. So we have devised a simple method, a clinical method to find out. This is called Indian Diabetes Risk Score. It is a simple 2-minute test which is based on 4 simple questions. What's your age? Do you have a family history? Do you exercise regularly? And how physically demanding is your work occupation? And in addition, the waist measurement using an inch tape. Next, please. Next, please.
Sorry, yes, sir.
So then we can do a scoring system based on these 4 questions or 5 questions. Then age. If the age is less than 30, the score is 0. 30 to 49, the score is 20. If you are more than 50, the risk factor becomes at a score of 30. If your waist circumference is within normal limits, it is scored as 0, 10, and 20. Again, based on the physical activity, you are labeled as 0, 10, 20, or 30. The family history again is scored as 0, 10, and 20. So depending upon your categorization, we total the score. And if the score is more than 60, you are at a very high risk. For example, if you are elderly, your waist circumference is high, you are sedentary worker, or you have a family history, your risk comes high. But between 30 to 50, it is moderate risk. I'm sorry for the typo. And less than 30 is low risk. So based on this criteria, by asking 4 simple questions, you can narrow down your people who need this particular screening. Next, please. So this is how do we grade our physical activity for calculating the score. If you are sedentary, the score is 0. If you are mild, it's like that. So depending upon your exercise capacity or your physical activity at home, then you score yourself like this. Next, please. Based on the system, then you can go on for the screening method. Now, what are the benefits of this Indian Diabetes Risk Score? 4 questions strategy, and then getting the score as low risk, moderate risk, or high risk. It is simple and inexpensive. Please go back.
Back? Okay.
I'm not sure. It helps to detect undiagnosed diabetes in the community. It helps to classify type of diabetes. For example, distinguish type 2. It distinguishes type 1 and type 2 diabetes. It also helps to detect metabolic syndrome and coronary artery disease. It helps to reduce the screening cost, and it is very helpful in creating awareness and preventing diabetes. Can I have the next, please? Okay, then what screening test to be done? What should you do as a test? Should you do an oral glucose tolerance test, a fasting glucose, a random glucose, HbA1c? What should we do? The gold standard for diagnosis of diabetes has been the OGTT. However, this is often difficult to perform in the population setting or for opportunistic screening. The subject needs to come fasting. Glucose should be loaded onto him, and then we need to draw 4 samples leading to multiple vein punctures. So it becomes difficult to carry out OGTT as a screening procedure. Next. So what we've decided is a random capillary glucose test should be done with the cut points that discriminates diabetic and pre-diabetic subjects. In Asian Indians, those with the random capillary blood glucose of more than 110 milligram per deciliter, using opportunistic screening can be recommended to undergo a definitive testing. If the random sugar is more than 110, then they should be sent for the further testing. And if the reading is more than 140, then they are labeled as diabetics, because more than 140 is always diabetes or pre-diabetes. Next, please. Now, if you have got a positive screen here, then how do you follow? If the diagnosis is diabetes, we start management in the form of lifestyle modification, drugs, or the other things. And if normal, we repeat the screening every 3 years in normal patients and every year for high-risk patients. But in case you find impaired glucose tolerance or impaired fasting glucose, then we repeat the screening every year to find out whether the patient has progressed to full-blown diabetes, yes or no. Next, please. No, this is as to how do we screen the diabetic patients, the community, for finding out the diabetes at an early stage, whether they are having pre-diabetes in the form of an impaired fasting glucose or an impaired glucose tolerance, whereby we give a load and then we find it to be intolerant. I'll again repeat that the natural course of diabetes derives from the normal individual to pre-diabetes, to clinical diabetes, and then to complications. The point to emphasize here is that every stage is preventable. At the normal stage, in case we find out people and we take certain measures, we can prevent diabetes from happening. In pre-diabetes, definitely, we can delay or defer the happening of diabetes. Similarly, up to the stage of clinical diabetes, again, if we make effort, we can either delay and defer, or at times, we can reverse diabetes as well. Next. So, not to whom should the prevention strategies be aimed? More so, the patients who are pre-diabetic, for example, those who are having impaired glucose tolerance, or those who are having impaired fasting glucose, where the fasting glucose is high. Let me tell you one small thing over here. The cutoffs are that if the sugars are between 110 and 126 as fasting, it is known as impaired fasting glucose. More than 126, it is diabetes. For PP, if the sugars are between less than 140, it is normal. Between 140 to 200, it is called impaired glucose tolerance. But more than 200 as PP, it is known as diabetes. So patients who are in pre-diabetes, either fasting more than normal or PP more than normal, but less than the diabetes criteria, should be given for the task for the prevention. And hence these individuals.
Should I go back?
Yeah. Hence these individuals are ideal candidates for application of prevention strategies. So Indian diabetes risk score represents a cost-effective way of selecting individuals for screening and prevention. Next, please. So how best can the prevention be achieved? Dietary modification, physical activity, drugs, or a combination. So let's have a look at what is happening. What is more beneficial out of these things? My next slide, please. So there has been trials to how to prevent diabetes. People who have been having pre-diabetes have been followed up with different programs where they have used different strategies. People have used lifestyle changes alone, diet alone, exercise alone, intervention alone. Certain drugs have been used as acarbose or metformin or rosiglitazone. So there have been different type of results. But one thing is very sure: if we intervene, we do get results. Next, please. Yes. So there has been a study, a Finnish diabetes prevention study, where there were 522 subjects and 4 years follow-up was seen. In case there was no intervention, then 23% developed from pre-diabetes to diabetes. But in case we had lifestyle changes, then there was only 11% people who developed the diabetes. That means there was significant reduction by intervening in the form of lifestyle changes alone. 58% reduction was seen by application of the lifestyle disease changes. Next, please. Similarly, let us have an evidence for effectiveness of pharmacological interventions in the prevention of diabetes. For example, there was a diabetes, metformin alone led to the reduction by 31%. But believe me, the lifestyle changes led to the reduction by 58%. That is, lifestyle changes are much more important than the drug interventions. Now, what to do with the lifestyle modifications? We recommend modest weight loss, that is 5 to 10% of the weight, and we recommend a modest physical activity, 30 minutes per day, 5 days a week. That is, or we combine both the things, that we take care of the diet part by and leading to weight loss, and also we do a modest physical activity, thereby increasing the insulin sensitivity, reducing the weight, and then reducing the progression of diabetes from pre-diabetes stage. The advantages are lifestyle modification. It is safe, it is effective, it is inexpensive, can be advised for almost everyone, and it has got additional benefits on lipids, blood pressure control, CV health, and everywhere. So lifestyle modifications becomes the key of prevention in diabetes at every stage. At present, medications cannot be considered as the first approach of choice in preventing diabetes, and a better approach would be to screen all individuals at high risk for diabetes using Indian Diabetes Risk Score and a random capillary blood glucose levels test, and initiate lifestyle modifications in those of them who do not already have diabetes, those who are only at the stage of pre-diabetes, to prevent the diabetes. Individuals with high risk of progressing to diabetes, for example, who are having multiple risk factors, especially if they demonstrate a progression of hyperglycemia, may be given metformin to prevent diabetes. Next, please. So prevention studies do not come to an end once the person develops diabetes. In fact, every stage, as I told you, from the stage of pre-diabetes to clinical diabetes to other levels, we can always have a reversal or prevention. At birth, in case we want to prevent by preventing in utero malnutrition, it is called primordial prevention, where we take care of the fetus during its growth in the womb. And then at the level of pre-diabetes, it's called primary prevention. Once the diabetes has onset set, it is called secondary prevention. And once there are early complications and we want to defer and prevent complications, it is called tertiary prevention. Next, please. Secondary prevention means micro and macrovascular complications by good diabetes control. We can prevent that. There are three main approaches, which is very important. We need to do an early and tight control of hyperglycemia, We need to have a very, very good BP control of the order of 120/80 in adults. And also, we need to have a correction of dyslipidemia, exactly not hyperlipidemia, whether it is due to do with the high total cholesterol, high LDL cholesterol, a low HDL cholesterol, or a high TG. Everything needs to be corrected by way of having a very, very good control with the help of lifestyle modifications and drugs, reaching the targets in every single patient. And tertiary prevention is where we lead to this limiting physical disability and rehabilitation measures in those who have already developed diabetic complications. For example, in early stage complications, the early approach would be to educate, detection of risk factors, some drug therapies. At intermediate stage, we need to take care of the extensive measures to correct the risk factors. And of course, once it is late, the surgery is the only option left. So by these methods, at every possible stage, whether it is pre-diabetes, clinical diabetes, or even complications, prevention stays as the key. The best is not to let the diabetes happen in patients who are prone to it. For example, patients who are obese, those are having family history, those who are been found to be having pre-diabetes, they must be given adequate measures to take care of the preventive aspects of the diabetes. We can skip that. You can. To conclude my talk, let me tell you, type 2 diabetes is preventable and at times reversible. We need to detect individuals with impaired glucose tolerance and impaired fasting glucose and a direct prevention strategies, and we should do direct preventive strategies towards them. Lifestyle modification is the key to prevent diabetes. Drugs may have a role in certain cases. For example, there are multiple risk factors, strong family history, people are obese, there's progression of hyperglycemia. There we may add a metformin to that. And even after the diabetes has developed, a good control of glucose, the lipids, and BP can prevent further complications. Thank you. Thank you very much. Here, I just like to add one small thing. Dr. Maninder, we are sitting in the midlife symposium. But believe me, that's not the age where we'll start looking at the lifestyle modification. Early should be the target. We must tell the discipline, and we must teach the discipline early in the years where people are school going. We are having these days childhood obesity. A person who stays obese for 40 years at midlife, you cannot modify him. So the children should be picked up fast, early. Schools should be targeted where children should not be allowed to develop obesity. We are having, my Dr. Bansal will be telling you that how prematurely we are having coronary disease. Let me tell you, we are having type 2 diabetes today in the ages of 17 years, 18 years, 19 years, 20 years, and even childhood obesity of the type of type 2. So we must educate our parents, we must educate the community, we must educate our school children not to become obese, stay active, stay alert, and they must take all sports measures, and they must take all exercises on a daily basis routinely, and to stay away from the fast food every day. With these words, I must thank Dr. Maninder Ahuja once again, for inviting me to this esteemed panel. I'm very sure Dr. Bansal is going to throw a huge light onto the prevention of the coronary disease. And Dr. Pandey has already taken us to the space and sky in the future, where we are waiting for the magic bullet to happen. and expect our longevity to up to 150 years or so. Thank you once again.
Thank you, Dr. Rakesh Gupta, sir. You have highlighted all the important aspects. Regarding prevention, sir, I just wanted to add one thing more. There is a lot of chrono disruption now amongst adolescents. I mean, they do not have proper sleep-wake cycles. They eat late in the night. And I think that is an important cause which is leading to metabolic syndrome and diabetes later on. So what are your comments about that, sir?
You're absolutely correct. In fact, what I tell my patients is that in fact we are having a food centric society. हमारा सारा जो जीवन है वो फूड के अराउंड घूमता है. जन्म फूड से है, सेलिब्रेशन फूड से है, मरने पर भी मृत्यु भोज देना है वो भी फूड से है, व्रत उपवास फूड से है, everything we see food all around us, and people are trained. किसी के घर जाएंगे तो क्या खिलाया, कोई आएगा तो मैं क्या खिलाऊंगा. So that food leads to the obesity syndrome, and they're not sensitive about it. So they draw pleasure in food. So that is one of the big reasons of evolving this obesity. And we are having an epidemic of obesity because of the affluence. 60, 70 years ago, we were having famines. We didn't have enough grains. We didn't have enough milk. So then the body was adjusted to small meals and small things. But today there is a plenty of food all around us, and we are eating only and nothing to do. And with the urbanization of the society, everything comes under the remote control. अब सोचना पड़ता है, काम हो जाता है. बेल बजानी नहीं, फोन उठाना नहीं, दरवाजा खोलना नहीं, कपड़े धोने नहीं, कुछ और काम करना नहीं. So everybody is relaxing, depending on the servants to do all the jobs. Again, leading to the lifestyle changes, leading to obesity, inactivity, rising insulin resistance, and setting of the NCD in the early childhood only. So we need to educate our population that please stay away from the lavish food, stay away from the fast food. Let this child play in the outdoor, not on the indoor on a video game. The child must be forced out into the community to play in the schools or play in the fields. And we must evolve our community in the way where playgrounds are available to our children, which are not available practically in any urban area today. So that's the message I want to convey to all the community members and my friends as well.
Yes, sir. Lack of sleep and these night shifts, they are also making our adolescent and young adults, prone to night eating and,
I believe that's a choice. That's not forced upon any one of them. It is their pleasure. They stay late up to the night, 2 a.m., 3 a.m., 4 a.m. The party is going all around the night. They come back early morning home, 4 o'clock, 5 o'clock, 6 o'clock. Nobody asks.
So I'm talking about night shifts, like means night workers who are working like doctors. They are also working night shifts. They are not getting adequate sleep.
If it is continuous, it is going to put a hamper on that. But we all doctors, nurses, paramedics, railway station people, airport people have been doing night shift and rounds. The physiology adjusts to that.
Yes.
But doing it for continuously over a period of time may lead to certain difficulties. But we as human beings are very fast to adapt. I am very sure in case you want to still modify your lifestyle, you can still maintain a very healthy lifestyle, despite the fact that you are working in a night shift.
Thank you,
sir. That's not a deterrent to your healthy lifestyle.
Yes. Zeenat ma'am, Rubina ma'am, your comments.
Yeah, I just want to say something. Anita, I wanted to say that if we ask our population not to eat and to limit their food, patients get upset with me when I tell them that they need lifestyle modification. Maybe they're looking at me and thinking that she doesn't do any lifestyle modification herself and she's only lecturing. So I think that we need to find smart solutions, and those smart solutions need to start from the childhood upwards. So providing safe spaces to the children to play, providing playgrounds in the schools, because most of the schools, especially in Pakistan and I'm sure in other countries too, because of limitation of space, the schools are shrinking. And the only thing that is available in the school is the classroom. So we need playgrounds for the children. And then if we want to create a health conscious society, in all the places that we work, in the colleges, in the universities, in the offices, we need to have spaces for physical activity. So maybe a gym in every office, it is going to increase the cost, but this is what is going to create a sensitization and awareness that the organization we are working is health conscious organization who's worried about the health of its employees. And the employees are encouraged to do activities which are physical activities in terms of 6 monthly activity or a yearly activity or celebrating a health day or something. Snacking again, then encouraging foods instead of all those things that we eat which are rich in oil. giving feeders of Coca-Cola to the babies, so things like that. I think I agree that we keep on saying that they need to eat less and a good quality food and healthy food and change their lifestyle. But we have to, as society and as the government, we need to develop an interdepartmental link so as all the related departments put those legislative measures in place so that we ensure a healthy lifestyle for not only for the children and adolescents, but for the adults as well.
Thank you, ma'am. Zenat, ma'am.
I advise my people is that they need to earn their food. They need to earn their calories.
Yeah.
Earn their calories and then earn their calories. I don't tell them that don't eat this much. Whatever you want to eat, kindly eat. No issues on that. But then you must maintain your targets within your limits. Your weight should be within your normal limits, either height or body weight. You should be maintaining your blood pressure and you should be maintaining physical activity. Whatever you want to eat, you may eat. I don't stop them from eating that. But they must burn and then earn.
Just one small point, we have to also focus on the quantities. So, you know, pregnant women, when you tell them that you can have food, you can have nuts. So they are going to have a bag of nuts rather than having a couple of nuts. So we need to change the attitude in terms of quantity as well.
Yeah.
Madam, urbanization has led to change in the food style of all of us around us. The dinner table has changed, the breakfast table has changed, the lunch table has changed. The food on our table has entirely been replaced by the ready-made food or the fast food in routine in general. Swiggy and Zomato are doing a huge business these days. I must not tell you. So we need to change a cultural change, which starts from the parents and then the young adults. And we also need to put this, say, pleasure image or bright image into the healthy living and healthy systems. Then only we will be able to bring a cultural change. It definitely, my friend, this follower, Dr. Piyush, I'm very sure will throw more light onto the weight management and the lifestyle management. But a cultural change has to be brought in again. We need to go back to our roots. I normally tell them, भगवान राम ने जो वनवास में खाया था कंदमूल, आपको वही खाना है अगर सही रहना है तो. So that relation also is very important. That tell them what is important, what is not.
Dr. Rakesh Gupta, I think the one point which I want to highlight is about your comment about midlife clinics. The way is happening this, we are looking into adolescent health, all of us. We have adolescent clinics. We are looking into pregnant health. But once they have delivered, they go back to their families. They get busy in looking after children. They look at education, their marriage, everything. And along that time, sometimes they go into menopausal transition and postmenopausal, and all the changes suddenly happen of metabolic syndrome. That's why somewhere along line, if we start giving them midlife clinic, even the men, they get busy in their jobs, in their businesses, everybody evolving. So that is the time period when if we can catch them, if we were not able to catch them earlier, at least at that time, if we catch them, we will be able to prevent many things.
From gynae and our point of view, two important things happen with obesity and poor lifestyle. It is the PCOS and it is the gestational diabetes, which is going to happen. So as obstetrician gynecologists, you must focus on the lifestyle modification and maintenance of the weight of your young adolescents, because they are going to land into problems otherwise, suffering from PCOS as well as gestational diabetes.
Of course, our intergenerational changes are also there. So we have to target that also. Very rightly highlighted by you regarding GDM and PCOS, because they are genetic. They have their genetic origin also. So we have to look after the intergenerational.
Short of time, I think we'll call the next speaker.
Zenat ma'am, you can call the next speaker.
Thank you very much, Dr. Rakesh, for your illuminating, brilliant presentation. Okay, fine. So can you have the slide for the next speaker, please? Actually, diabetes is a slow motion disaster, no doubt. Well, it's my honor to introduce Dr. Shyam Sundar Bansal. He is the chairman and managing director of SSB Heart and Multidisciplinary Hospital, Faridabad. Already Dr. Maninder said that he is a very renowned person among the three. He is a renowned interventional cardiologist with experience of 30 years in the field of heart disease management. He is the first qualified DM cardiology of Haryana state, and he started the first dedicated heart hospital in the state of 2002. It's so wonderful. I mean, and he started his professional career as a first cardiologist in Haryana in 1994 in Escorts Hospital at Faridabad. And in 2002, he started his first dedicated heart hospital in Sunflag Hospital, where he introduced many heart procedures for the first time in the state. And in the year 2020, he started SSB Heart and Multispecial Hospital. It's really wonderful, Dr. Sham. And he has treated more than 2 lakh heart patients so far successfully and has performed more than 50,000 heart procedures, including the complex angioplasties, pacemakers, and rotablasts, OCT, IVUS, pressure wire, heart hole closure without surgery. And his vision is to make SSB a sought-after destination for healthcare by patients from India and abroad. And mission, it is to make the healthcare service more affordable. He is the pioneer in introducing several procedures for the first time in North India. His special area of interest is complex angioplasties of the left main coronary arteries and chronic total occlusions and bifurcation blocks. It's a really difficult job. He is a pioneer in the country to use the crusade, corsair, and retrograde techniques for very old, hard, and difficult blocks. And it's a tremendous job. He is honored by district administration on Republic Day and conferred the Rashtriya Gaurav Award for his distinguished service to the humanity. IMA honored him for highest number of angioplasties in 2011. He was also a recipient of Entrepreneurs of the Year Award. He's a highly talented, extremely dedicated to his work and quality oriented. Dr. S.S. Bansal has trained many cardiologists over the past 20 years. May I welcome this warlord, Dr. Syam Sundar Bansal, for your presentation, please.
Thank you, Madam Jeenat Nasreen, for your kind introduction. Good evening to all the conveners of the conference. Particularly, I would like to thank Dr. Maninder Ahuja and the entire society of elegant speakers and such great doctors who, and particularly I am thankful to this organization for organizing a talk on a very, very important subject of non-communicable diseases. Of course, the most important period for taking care of your health is 40 to 60, because most of the non-communicable diseases do occur during this age group. But I would like to appreciate what Dr. Rakesh Gupta was mentioning, that we need to start looking at the health of children from even before puberty. You know, we have to detect whether they have a familial hyperlipidemia. After puberty, also at the age of around 20 years, we have to find out whether they have any risk factor for the development of non-communicable diseases. So it should start very early at the level of school, because see, in the last, when I joined Escorts Hospital in 1994, that time coronary artery disease, which is my topic, that was a rare thing to happen below the age of 35. But as the time has passed, in the last 25 years of journey in Faridabad, what I have observed is in the last 10 years, I'm getting more and more younger and younger patients who are in the age group of 20 to 35. In the last, say 100 patients who were below the age of 35, I did the analysis. I found that 99% of them were males, and about say 90% were smokers. So, and the children in the school, they start smoking very early, and that is where, you know, the awareness to in the school should also be created, so that they can adopt the healthy lifestyle in their younger age group, so that they don't develop non-communicable, particularly coronary artery disease or cardiovascular disease in the middle age group, that is 40 to 60, what we are talking about. So how it should be prevented, that is the subject of discussion today for me. Coronary artery disease, of course, is the most preventable non-communicable disease, but still more than 25 lakh people die of it every year in India, which is much more than the huge number of COVID deaths which we have witnessed in the last 1 or 2 years. And we know that the entire world was shaken with the number of deaths COVID caused. But if you see, 2 crore people are dying of heart disease or cardiovascular disease all over the world every year. And in India alone, we are losing around 25 lakh patients just because of heart attack. So the number is so, but because it is happening every year, so we are really not much worried about it. It does not make any news. It is not taken seriously by the people. But COVID, because it has happened for the first time in the world in the last 2-3 years, that is why it was in news all over the world in all the channels every day. So therefore, because it is causing so many deaths, so we need to create awareness about its prevention in our country. Now, cause of coronary artery disease is atherosclerosis in more than 90% of the patients, but there are other causes like Takayasu arthritis, vasculitis. Vasculitis can cause thrombus formation in the coronaries, and vasculitis can happen in patients who are suffering from polyarthritis nodosa, Kawasaki disease. It can happen in patients with the giant cell arthritis. So there, and the antiphospholipid syndrome, which is there in females, in many females. I had a patient who had antiphospholipid syndrome. She had history of recurrent abortions, and she also had history of DVT, and she presented with MI to me. So basically the problem was this antiphospholipid syndrome was confirmed by doing certain tests, and the thrombus was detected in her coronaries. So this is also, one should keep in mind that the rare causes also should be kept in mind. Now the coronary spasm of course is a very rare phenomena, but it happens when the patient during the midnight or early morning, the patient is getting chest pain, and otherwise TMT is normal. If the person is undergoing non-invasive tests, they are normal, but the patient is complaining of chest pain in the early morning. That could be due to coronary spasm, because that is the time when it happens. And particularly tobacco or any form of tobacco, particularly if they are smoking in the morning, then there are chances of coronary spasm. Then cocaine, some people who take cocaine can have coronary spasm. The other important is emotional stress can sometimes precipitate coronary spasm. Therefore, we need to prevent. So for preventing coronary artery disease, what we need to focus is to prevent, how to prevent atherosclerosis. For the development of atherosclerosis, we have to focus on that. Then only we can prevent the development of cardiovascular disease. Now, see, this I think everybody knows how the prevention is not only primary prevention. The prevention also involves secondary prevention and tertiary prevention. For primary prevention is, of course, everybody knows that it is before the development of the disease. Healthy lifestyle changes, vaccination, all these things are required for primary prevention. But in case of atherosclerosis, now the scientists are trying to develop a vaccine which can control or reverse the process of atherosclerosis. Nanotechnology is also being investigated which can reverse atherosclerosis. At present, we do not have anything which can reverse the atherosclerosis. We can only control the progression, we can slow down the progression of the atherosclerosis, but we cannot cure it. At present, there is no cure of atherosclerosis. We have to just prevent complications and progression of the atherosclerosis. For secondary prevention, we need to screen people at an early age. Periodic screening is required for assessing the risk factor of CAD. All boys and girls should be screened for blood pressure, BP, lipid profile at the age of 20. For CAD detection in asymptomatic patients with the risk factors should be screened to rule out CAD. What are the screening tools we have? TMT, coronary artery calcium. Then we have, all these CT angio, stress echo, nuclear scan, all these things are there, which can help in doing secondary prevention. That means detecting the disease at early stage. Now, tertiary prevention also, we should also talk about tertiary prevention, which means to slow or stop the progression of established coronary artery disease and its complications. For example, we give antiplatelet drugs to prevent the formation of thrombus, thereby causing MI. We need to control the progression of atheroma by giving statins, or by sometimes we give even Repatha, new drug. And nanotechnology is being, being under investigation for, dissolving the atheroma, for, injecting particles which can, which can dissolve the atheroma. And for example, and vaccination also, which can create antibodies against the LDL and other elements of the atheroma. But those, basically the vaccine is being developed for, causing sort of immune system, for activating the immune system, which can protect the body from atherosclerosis. The other important drugs which are preventing the progression of heart disease to heart failure also is a type of tertiary prevention. And we need to, in post-MI patient, to prevent LV dysfunction and also to prevent the progression of LV dysfunction, we need drugs like beta blockers, ACE inhibitor, ARB, ARNI, mineralocorticoids, SGLT2 inhibitors, and ivabradine. So appropriate combination of drugs is extremely important for tertiary prevention of coronary artery disease, for prevention of heart failure, and also to prevent recurrent MI. Angioplasty and bypass also is not a cure. Angioplasty and bypass surgery is also required for preventing myocardial infarction and heart failure. So that also is a type of tertiary prevention. It is not a curative treatment. So in case of CAD, we have to adopt all three types of prevention, and all these things are important. Other thing is we want to prevent death from coronary artery disease. So all these things are helpful in preventing death from coronary artery disease. Now, because of the advancement in cardiology, people in US, there was a study that, patients who are having coronary artery disease, they were dying of heart failure or sudden death because of cardiac arrhythmias. But now, because of the advancement in treatment, people are undergoing screening tests frequently every year. They are going several times, they undergo angiography. And whenever there is a disease at a critical stage, it is basically, they control it with angioplasty or bypass surgery. That is why 20 people with heart disease, which was detected, say 30 years back, are still alive. So people are not dying of heart disease because at various levels, you have interventions which can prolong the life of the person. So, and it was observed that many coronary artery disease patients who are living for 20, 30 years are actually dying of, more of them are dying of malignancy rather than coronary artery disease. So that is what we have achieved a great, we have great advancement in preventing deaths from coronary artery disease. And 80% of the premature deaths from heart disease can be easily prevented. The only thing required is awareness. We all know about coronary artery disease, their anatomy, endothelium, the role of endothelium. Endothelium of the coronary artery is the most active layer, where all the risk factors basically cause damage to the endothelium, which is the innermost active layer of the coronary artery. So what we need is to keep our endothelium healthy. So exercise also basically improves the function of the endothelium. Now, another important thing which I would like to highlight is that most of the patients, they in non-invasive test can detect when the person is having 40 to 50% of stenosis, even up to 70% of the stenosis. Non-invasive testing or clinical assessment cannot make a diagnosis of coronary artery disease. So that is why, it is very important to detect the disease at this level when the block is less than 70%, because this block will slowly progress over time, and it may slowly progress, maybe from 40, 50%, it may go to 60, 70, 80, and 90 over years. And then when it becomes more than 70%, it causes angina, which can be stable angina. So then that can be managed with medicine. But in some people, the block, which is around 40-50%, can rupture, exposing the cholesterol, attracting the platelets, and then they can make a clump or clot there, which can cause sudden occlusion of the coronary artery and leading to serious heart attack and sometimes sudden death. So because of sudden death, 20 to 25% people, they die suddenly. The first presentation is death only. So that is why it is very important to detect the coronary artery disease at the stage when the block is, say, around 40-50%. When you detect it at this stage, you can control it with statins, you can control the risk factors, and you can control it without doing any angioplasty or any serious intervention. But the problem is this block cannot be detected by ECG, echo, and TMT, which are routine investigations. This block can be detected only with either CT coronary angio or standard coronary angio. But in my subsequent slides, I'll be talking about how to detect the disease at this stage and who are the people who should be screened for this. Now, another important aspect is, everybody, all doctors should understand that the angina is of three types: typical angina, atypical angina, and non-cardiac chest pain. Now, typical angina, when all three components like substernal chest pain, typical areas of chest pain, when the pain is confined to that area, and when the pain is coming on exertion, particularly, and when the person starts exerting, he gets pain. When the person stops exerting, the pain is relieved, or the pain is relieved by taking sublingual sorbitrate or nitroglycerin. So when all the three components are there, it is typical angina. And when the person is having typical angina, one can straightway go for a test, which is a coronary angiography, gold standard test. If the patient is having typical angina, and if the patient is not having typical angina, but ECG is showing ischemic changes or echo is showing regional wall motion abnormality, then also a person should go for coronary angiography. But if only two of these symptoms are present, we call it as atypical angina. Then also all these patients should undergo ECG and echo. If ECG is atypical angina, if ECG is normal, echo is normal, but these two symptoms are present, then we can go for CT coronary angio to detect the disease. But if the patient is having non-cardiac chest pain with normal ECG, normal echo, we can give an option of TMT or stress echo in these patients. Now, all of us know what is typical angina, what are the areas where the chest pain should not be ignored, where the cardiac pain can occur in the center of the chest, across the chest, in the throat, in the lower part of the jaw, left shoulder, right shoulder, left arm, right arm, both arms. So all these areas are the areas where, the pain should not be ignored, and person should be subjected to at least ECG and echo, and based on that, the further step can be taken. The other important aspect is that, when you do the ECG, if it shows ST elevation or ST depression and T wave inversion, then it should not be ignored. One can straightway go for, and particularly if it is correlating with the symptom of the patient, typical symptom, then one should go for directly angiography. If ECG is normal and the pain is atypical or non-anginal, then one can go for stress test. A stress test can be exercise stress test, or it can be drug pharmacological stress test. But if the patient is having abnormal echo, in between stress test and ECG, one should do echo test also, echocardiography. Echo color Doppler is available in almost all the cities nowadays. And if echo is abnormal, then one should go directly for angiography rather than subjecting the patient to stress test. We have seen deaths on treadmill tests, so it is very important that any person who is at risk of heart attack should not be subjected to stress test. Now, before coronary angio, if some patients have phobia for coronary angio, they can undergo CT coronary angio for screening purpose. Of course, this is what we are talking about. This is of cath lab. The patients who are having less than 70% block, or the block in small branches, can be managed very easily with very good anti-anginal, antiplatelet, and statin therapy. The patients who have more than 70% block in major coronary arteries or large branches, They need angioplasty and stenting to prevent future events of unstable angina and MI or LV dysfunction, heart failure. They require angioplasty. The patients who have left main with diffuse critical coronary artery disease, which is with particularly diabetic patients with LV dysfunction, these are the patients where a left main or LAD and LAD is also involved. They are the persons who get maximum benefit by bypass surgery. But all these modalities, I tell you, are not curative. They are all preventive, because they only postpone the death, they only postpone the heart failure, they only basically give you more life, so that longer life, so that you can start preventive strategy. Even after angioplasty, you need prevention you need to prevent the progression of atherosclerosis. Even after bypass surgery also, you need medication to prevent thrombus formation, to prevent progression of atherosclerotic disease, to prevent a remodeling of heart. So even after these major procedures, one should not relax. One should remain vigilant. One should remain in touch with the cardiologist and take appropriate medication to prevent future complications. CT angio is a wonderful thing, non-invasive test. Many people who are afraid of coronary angio, they can just a venous puncture is required and 70 ml of non-ionic dye is required. The scans are so fast, and there is such a good software that it can practically rule out coronary artery disease in a patient where you are suspecting heart disease. You can rule out coronary artery disease with 100% surety on CT angio, and you get a fair idea about the extent of disease from this CT angio these days. Now, who should undergo CT coronary angiography? Patients who have chronic stable angina, who are not willing for gold standard coronary angio, they should at least go for CT coronary angio, because this is more accurate than PMT and other imaging tests for future risk assessment. Patients with known diagnostic or equivocal stress test for diagnosis of CAD, these patients also should undergo CT angio. Patients who develop left bundle branch block during exercise, you cannot make a diagnosis whether the patient is having coronary artery disease or not. When the patient develops LVVB, then these patients also should be sent for CT coronary angio. And when the changes are borderline equivocal, then also the diagnosis can be made only by CT angio. Possible acute coronary syndrome. Patients who present in emergency with chest pain and you suspect unstable angina or MI, but ECG and echo are not clear, and TROPT test is also inconclusive, because TROPT test also becomes positive after some time. So sometimes, in emergency, you are not sure whether patient is having acute coronary syndrome, means MI or unstable angina. Sometimes the changes are not clear on ECG and echo also. Then you need CT coronary angio can rule out or can establish the diagnosis of acute coronary syndrome. ST depression and T-wave changes in ECG with no symptoms. When sometimes you have ECG changes, but patient is not having any symptoms. So there is no, clinically, you are not able to correlate the changes of ECG and echo and with symptoms, there is a mismatch. Then also CT angio should be done to rule out, because silent heart disease can be there. To assess the patency of bypass grafts, if you are suspecting that some of the bypass graft might have occluded, then CT angio is the best modality to see the occlusion of the bypass graft or patency of the bypass grafts. High risk individuals with multiple risk factors. Many doctors are coming forward these days, those who are diabetic, those who have family history of heart disease, hypertensive, smokers. They come for CT coronary angio just to be sure that they are not building up atheroma in the coronaries, because CT angio is one modality which can detect even 10-20% of atheroma if it is building up in your coronaries. When should we not do CT coronary angio? If the coronary artery calcium score is more than 600, then the calcium will not allow you to see the lumen clearly, and CT angio information is not reliable. So that if it is less than 600 calcium score, first, so before doing CT angio, calcium scoring should be done. If calcium scoring is very high, one should then stop and do not inject the dye to do CT coronary angio. If patient is having persistent tachycardia, the RR interval is so short that the images cannot be properly acquired. So blurred images and you will not get a fair idea about the coronary artery disease. Irregular heart beating, again, CT angio should not be done. If the person is allergic to contrast medium, that also is another problem. Acute coronary injury, acute kidney injury patients also should not be subjected to CT coronary angio. Patient is having breathlessness. If the patient is breathless, then they can't hold the breath in the CT. So then also you cannot get clear picture about the CT angio. So those patients should be subjected to standard coronary angio. This is the picture of CT coronary angio. This is the picture of normal angio. Just for comparison purpose, LED critical block here and LED critical block here. Both are, give quite a good idea about the presence or absence of coronary artery disease. Another important advantage of CT coronary angio is that if the person is having chest pain, presents in emergency with chest pain and is looking sick, if the person is absolutely having chest pain, nothing else is there, then you can assess the patient in a different way. But if the patient is having chest pain with low blood pressure or breathlessness and the patient is really looking sick, then CT coronary and CT angio, where there is a feature of triple rule out, in which you can rule out acute coronary syndrome, aortic dissection, pulmonary embolism, tension pneumothorax, pericardial tamponade, mediastinitis. All the life-threatening emergencies which can cause chest pain can be ruled out only with a single test, which is CT angio. Now, all of you, because all of you are doctors, you all know that risk factors for the development of coronary artery disease are age, family history, high blood pressure, diabetes, deranged blood lipids, smoking, physically inactive people, obesity, and then psychological stress. There is one more risk factor is kidney artery disease. If the person is having CKD, means end-stage kidney disease, they develop atherosclerosis very fast. That also is a very big risk factor. After menopause, the risk of development of coronary artery disease is same in females, it is similar to the men. And because you can control all the major risk factors which are responsible for the development of coronary artery disease, all these are major risk factors. 80% of the patients fall into this category, and 80%, that is why we say that 80% of the premature or coronary artery disease can be easily prevented if you control the controllable risk factors. Of course, these are the risk factors where you have no control: age, gender, race, and family. So but at least you can do something about it. Now, diet should have appropriate nutrients. If you want to prevent coronary artery disease, you have to take healthy diet. What is healthy diet? Our diet should have macro and micronutrients. Protein should be 20% of the calories, which suppose the person is healthy person who is physically and quite active, and he will definitely take at least 2000 calories. And out of 2000 calories, he should take 20% protein, means 100 gram protein he should take, 30% fat, which means 45 ml of oil or ghee. So 45 gram of oil he should take. And for carbohydrates, 50% calories should come from carbohydrates, which means 300 gram of carbohydrates. So his diet should be balanced diet. For balanced diet, we should have this kind of combination. Calories should be 20% from protein, 30% from fat, 50% from carbohydrates. The diet should also have vitamins and minerals. Now, when we are talking about 30% calories from fat, then we should know what is good fat, what is bad fat. These are the three bad fats which increase the bad cholesterol, LDL. Saturated fatty acids, unsaturated fatty acids, and cholesterol. These are the things which we should limit, because most of the diet, our Indian diet, contains saturated fats and cholesterol. But what is good for us is the polyunsaturated PUFA, polyunsaturated fatty acids, and monounsaturated fatty acids, MUFA. Practically, our diet should have 10% saturated fats, 10% polyunsaturated fats, and 10% monounsaturated fat. So that is why if we have to take 45 gram of oil per day, then that means 15 ml or 15 grams should come from these things. 15 grams should come from these things: mustard oil, olive oil, and groundnut oil. And also 15 gram or 15 ml should come from the polyunsaturated safflower, sunflower, cottonseed, and so these oils. So we should have a combination of fat, and the trans fat are the worst fat, where the trans fat should always be avoided if you want to, because the fast food which the children are taking, they are they usually particularly the fried items from the market, they contain a lot of trans fat. The vanaspati ghee contains only trans fat. So trans fat is 10 times more dangerous than the normal other fats. Fruit and vegetables have a high nutrient density and a low energy density. Whole fruit and vegetables should be preferred over juice. Consumption of fruit and vegetables of 3 or more servings per day versus less than 1 was associated with 27% reduction in cardiovascular risk factor. Nuts are good source of monounsaturated fatty acids, fiber, and minerals. Walnuts and almonds should be taken in moderate quantity if you want to take healthy, polyunsaturated fatty acid in your diet. These things should be avoided, which contain only empty calories without any nutritional value. For example, French fries, fried chicken, chips, and deep fried. They can also, deep fried items contain a lot of trans fat also, which is the most harmful fat. Candy, colas, beer, wine, all these are empty calories. They do not have any nutritional value. And one should avoid white rice, white bread. Instead, they should take brown rice and brown bread. Cookies also should be avoided because the quality of oil is not good. Now, if for 2000 calories, one should have, depending upon your physical activity, you can have 6 to 11 chapatis or equivalent rice with minimal fat should be used with these cereals, and 2 to 4 fruit per day and 3 to 5 vegetables per day in the form of salad. And only 2 servings you should take for non-veg. Those who are non-vegetarian, they can take 1 or 2 servings of fish and chicken, but not mutton. Milk should be double toned. If you want to take more than 500 ml of milk, it should be double toned. If you take 250 ml, you can be, say, single tone milk also. Oils and sugars should be avoided as much as possible by everybody. As far as exercise is concerned, one should walk very fast as possible. We call brisk walk only if you can walk complete 1 kilometer in 10 minutes. That should be the ideal speed for getting good benefit of exercise. And 150 minutes of moderate exercise or 75 minutes of vigorous exercise per week is required for keeping your heart healthy. Any additional exercise, if you want to do, it will not help you further reduce the cardiovascular risk, but it may help you in reducing your weight and building your stamina. Supplemented by an increase in daily life activities like walking between the work, during the work, gardening, household can also help. Benefits, of course, exercise improves the endothelial function of the coronaries. So it prevents the formation of atheroma and progression of atheroma. Because that is why it decreases cardiovascular mortality, improves your blood pressure, improves your lipid profile, it raises your good cholesterol HDL, and also improves your diabetes. As far as smoking is concerned, it's a major risk factor, which I initially mentioned that most of my young patients between the age group of youngest patient which I treated with MI was 19-year-old boy 6 months back. He was also a smoker. And almost 90% of my patients, young patients, were cigarette smokers. So this is the most preventable and most important factor as far as coronary artery disease is concerned. And I will not go into the details of smoking here. But if you stop smoking, the risk starts decreasing within 24 hours. And after 2 years, the risk reaches the level of a non-smoker. Other benefits of smoking, of course, you know that it prevents cancer also. How to prevent, because it is a very bad habit. The addiction is so much that patients are not able to quit smoking despite counseling. So then, we tell them that instead of taking 4,000 chemicals, which you are inhaling with smoke, it is better because you are taking it for nicotine, just take nicotine rather than taking the whole cigarette. But nicotine, of course, for cardiovascular disease, nicotine is the culprit. So we do not recommend nicotine for to heart patients. Rather, we give them bupropion or vernaculine so that their craving for smoking is gone. Now, for stress also is one of the important factors which can contribute to the progression of coronary artery disease, particularly anxiety and depression. If people are having anxiety, depression, and they are not able to resolve by yoga, meditation, and behavioral therapy, we then recommend treat medicines also for depression and anxiety. And particularly, we tell them that you should think positively, you should care for others, think about others rather than about yourself, reject the thoughts of hostility, fear, hatred, and jealousy. These are the negative thoughts which can cause progression of your coronary artery disease. Even it can cause the rupture of the plaque and vasospasm. 10% reduction of blood cholesterol produces 20 to 30% decline in CAD deaths. But very important thing is that 2/3 of patients who are undergoing angioplasty, bypass surgery, they have normal cholesterol. So because cholesterol is not the only culprit. You should not assume that if somebody is having good lipid profile, he cannot have coronary artery disease. It is only one of the risk factor. Blood sugar is a very important. It is considered as, if you have diabetes, it is you have a risk of developing coronary artery disease more than 30% in 10 years. So that is why diabetes is considered as the most important risk factor if you are not a smoker. And one should control diet, weight, and exercise and take medicines regularly. And so the most important thing is that nobody should miss the diagnosis of blood sugar. If any person coming to a doctor the way we check the blood pressure for every patient, we should also check the sugar for every patient who is coming to the hospital. So checking sugar every time when the patient comes to the hospital will allow us to make the diagnosis of diabetes in time and prevent its long-term complications. Same way, blood pressure control is equally important. I will talk about the blood pressure, not in detail because we all know about blood pressure, how important it is. Dr. Rakesh Gupta has already highlighted that in all diabetic patients, the prevention is not only controlling by controlling the blood sugar level. The prevention also includes the control of blood pressure and also control of lipid profile in all patients who are diabetics. Role of aspirin in the primary prevention of cardiovascular disease has been controversial, but it has remained a concern. Recently, the data has come from USA that one should not take aspirin for primary prevention. But most of the data which has been collected all over the world, according to that, the low dose aspirin is less than 100 milligram. It is recommended for individuals aged 50 to 59 years. Here I am talking about primary prevention. For secondary prevention and tertiary prevention, we are not talking here. For primary prevention means no disease at all. When the person is absolutely healthy, in those patients who are 50 to 59 years of age, who have a 10% or greater risk of cardiovascular disease calculated by ACC-AHA. ACC is American College of Cardiology, American Heart Association. They have made a calculator which is there, you can download it on your mobile very easily. ASCVD. This is the score, atherosclerotic cardiovascular disease score. If that score, if there are certain factors like total, you have to fill age, sex, race, total cholesterol, HDL, BP, diabetes, habit of smoking. These are the parameters which you have to feed in the calculator. Then it tells you what is your risk of developing heart disease or cardiovascular disease in next 10 years. So if your risk is more than 10% and you fall in the age group of 50 to 59 and you do not have any risk of bleeding, then they recommend that for primary prevention, these aspirin should be taken. And the aspirin is safe. The benefit of aspirin is more than the risk of aspirin. The risk of aspirin is bleeding. In this age group, 50 to 59, those who are not at risk of bleeding, and who have more than 10% risk by calculating this ASCVD calculator on calculating their risk. If they find that the risk is more than 10%, then only they should take aspirin. ACC-AHA risk calculator can, the other thing is that, this of course I have already mentioned, but the calculator can be used to assess the risk score of more than 20-year-old, because otherwise this risk calculator has been validated for the age group of 40 to 75. So those who are falling in the age group of 40 to 75, they should use this calculator. Everybody, all of them should use this calculator. But if the person if less than 40 years of age, then also, but with family history of premature disease, then they can get their lipid profile and get their BP checked, and then they can use this score. And if the individuals who are in the, between 10 to 20% risk category, then we should see whether they have any risk of bleeding. If they do not have risk of bleeding, there is a score which is called as Has-Blood score. If your liver is abnormal, if you have prolonged PT, or if you are having bleeding disorder, or you are taking other drugs like acetylcholine, warfarin, or other drugs which can cause bleeding, then we should avoid. Otherwise, we should, these patients who have more than 10% risk or 20% risk must take aspirin even for primary prevention, even if they are younger than 40 years of age. Statin, the other important is for primary prevention, role of statins. Statins are so safe that they were available on counter without any prescription in USA. Today also statins can be purchased in USA without prescription, because they are very safe drugs and they are recommended for primary prevention much more than the aspirin. Aspirin is now restricted for primary prevention to a very limited group, but statins are not restricted. All individuals of 40 to 79 years of age with 10-year ASCVD risk of 10% or more, or a lifetime risk of more than 39% should be on statins. All diabetics, both type 1 and type 2, should be on statins. Persons with LDL of more than 190 milligram, that they should be on statins. Lipid profile should be done in all patients above the age of 20 years and before puberty in persons with a history of first degree relative having hyperlipidemia or premature cardiovascular disease. The people who are having premature disease, their children before puberty should also undergo screening for lipid profile. Documented familial hypercholesterolemia. In these patients, even statins may not be able to control the bad lipid profile. Repatha is a new evolumab. This is a monoclonal antibody which helps in controlling the LDL in such patients. Evidence of atherosclerosis on carotid Doppler, peripheral Doppler, coronary artery calcium, then CT or CT angio. If there is evidence of atherosclerosis, then statin must be prescribed to these patients to prevent the progression of atherosclerosis. Patients with multiple risk factor at a young age, even if their cholesterol is normal, they should be prescribed statins. Now, normally the concept of the doctor is that if cholesterol is normal, LDL is normal, HDL is okay, there is no need to give statin. But the concept is, the real concept is that if the person is having any evidence of atherosclerosis, whether on peripheral Doppler or carotid Doppler or coronary artery calcium scoring on CT or on CT angio, or patient who is having strong family history, diabetic patients, multiple risk factors, they should be on statins, whether their cholesterol is normal or not. Irrespective of the cholesterol level, they should be given statins. All patients with CKD, chronic kidney disease, the progression of atherosclerosis is very fast in kidney patients. They also should be given statins. Now, this is my last slide. First of all, we should identify the risk factors in a given person. Check their lipid profile. If LDL is more than 190, then that means they have familial hypercholesterolemia. Then they should be treated aggressively to prevent CAD. Lifestyle changes. Apart from lifestyle changes, they should be on statins and they should be given aspirin. And these are the patients who are at very high risk, those who are having LDL of more than 190. If their LDL is not in that range, then we have to see the age of the person. If the age is between 20 to 39, then we have to assess the other risk factors. This was only LDL. Then we have to see whether he's smoker, whether he's hypertensive, whether there is a family history of heart disease. So other factors should be looked into. And depending upon the other factors, if the person is low risk, then we can reassess the person after 5 years or till the age after 40 years of age. But if the person falls in the age group of 40 to 75, then we should calculate the risk of 10 years risk of coronary artery development of coronary cardiovascular disease by using the calculator, ASCVD calculator. And then if the person is in this age group, they are the most important. This is the most important group because most of the deaths or most of the morbidity and mortality is occurring in the age group of 40 to 75. So in this age group, we should always assess the risk, 10-year risk of cardiovascular disease with the help of calculator, ASCVD calculator. If the risk is less than 5% on calculator, and if the patient is having the age is 40 to 59, then we calculate the lifetime cardiovascular risk. If lifetime cardiovascular risk with the help of calculator is more than 39%, then they should be then they should be treated aggressively with statin and aspirin and lifestyle changes. If the person is having if the person is very young and the patient is not having any risk factor, then also every 5 years they should be screened. But if the risk is high risk people who are more than 20, the risk is more than 20% of, what is the risk? Basically, risk is after 10 years, there is a 20% risk of dying due to MI or stroke, or developing a stroke, disabling stroke, or developing a MI. This is what is called as risk. So if their chances are more than 20%, then they must be on statins, they must be on aspirin, then they must have good lifestyle, and they must get themselves screened by CT angiography, or even if they do not have symptoms, they should go undergo CT coronary angio to assess whether they have started building up atheroma in their body or not. If the age is more than 75 years, then we should not be very aggressive. We should, depending upon the clinical symptoms only, we should touch them. Otherwise, there is no need. Just modify the risk factors if any risk factor is there. But you should not be very aggressive. If the person is more than 75 years, then the person may be having other comorbidities. So depending upon the comorbidities, we have to manage these patients. Thank you very much for patient listening. I was really delighted, and it was a great pleasure to participate in this forum. Thank you very much.
Thank you, sir. Thank you for that exhaustive lecture. You have covered all aspects of coronary artery disease, how to prevent, what is the secondary prevention, and how to limit the further morbidities which may ensue. Thank you very much, sir. Dr. Rubina or Dr. Zenith, you have any comments to make, please?
Sir,
I just wanted to say one thing.
Wonderful deliberation. But particularly, I like the diet chart. It's wonderful. I mean, everybody learned a beautiful diet chart from him. Just I'm wondering one thing, as we're in midlife women, so do you have any idea, any thought about MHT can prevent? Is there any role of MHT to prevent the endometrial thickening of the blood vessels? Do you have any comment upon that?
He asked me, it's not about menopause. I told him, no, it's not about menopause.
No, just
are you talking about low dose estrogen?
Yeah.
Yes.
Okay. See, madam, the point is patients who have coronary artery disease or who have an evidence of atherosclerotic disease, the estrogens should not be given because they increase the chances of stroke and MI in this group of patients. So the low dose estrogen before starting low dose estrogen or in patients for osteoporosis or for their other reproductive system issues, then before starting them we should rule out coronary artery disease.
So there is one query.
That ELITE study, that is early versus late study of estrogen therapy, they have shown that it could reduces the intima and thickness. So probably if this doesn't have any atherosclerosis, it would be the right thing to prevent.
Madam, it can increase the chances of thrombus formation also.
Yes.
Oral contraceptives, there is a very clear-cut data that oral contraceptives increase they create a procoagulative state in the blood, and it can lead to thrombus formation.
Dr. Bansal, I agree on this point that if the atheroma formation is there, then the estrogen therapy is going to cause the disentanglement of the atheroma and CAD will be there. But if atheroma formation is not there, then with the risk factors we can prescribe. Now I'm presenting a case which I got today only. Because I'm doing a research paper, all of us, Jinnat and Rubina Hussain and everybody is with me. Sohail, everybody is with me because we are doing it in South Asian countries, relationship of menopause to metabolic syndrome. So I'm collecting a data on Google Forms and on the cross-sectional studies also. And the main data we are collecting is on the family history. Whether the family, mother, father, brother, sister, or the grandparents, they had the history of hypertension, diabetes, or coronary heart disease, or fragility fracture. So I had a patient today, 55 years of age. She was apparently healthy. And when I filled up her form, she told me the parents had died earlier, 20 years back, said that they don't know. But the brothers and sisters, they are all having CAD. She had their stent also. Now, she is hypertensive and she is taking her blood pressure therapies. When I got her lipid profile done, it was normal, but her blood sugar was borderline. She 180 was there. So it's now the question comes, she's having hot flushes, she's having night sleep disorders. So that was all on questioning because all these patients, they think they are healthy. So what should be investigation? In this case, with strong family history, should we get her CT angio done? Because apparently she is healthy. BMI is normal, weight is normal.
See, madam, what I would say is that if you are contemplating putting them on low dose estrogen, then it is better that you get carotid, and you can do carotid Doppler, you can do peripheral Doppler. If there is no evidence of carotid intima medial thickness, and if there is no atheroma in the carotid, and then you can subject them to stress test. But the way you are telling that if the patient had a strong family history of heart disease, then in that case, I would suggest that it will be better if her ECG, echo, and CT angio, all three are normal, then you can put the patient on low dose estrogen very safely.
Cost to the patient. These are low middle income group patients.
Okay, the cost of course is an issue. Then carotid Doppler, you can screen them for carotid Doppler. And if the person is not having diabetes, hypertension, lipid profile is normal, because the only issue here is that family history is very strong. So endothelial dysfunction may be there. So, and for endothelial dysfunction, carotid at simplest test is carotid Doppler. If carotid Doppler is showing increased intima medial thickness or presence of plaque, then it is better to avoid. If patient can afford, of course, CT angio will, because it's a menopause. After menopause, the females are at risk of heart disease. They can develop CAD.
That is what we are trying to find out by our study now. What are the risk factors? What are the symptoms? Because I have gone through studies where they are doing the cluster of symptoms of menopause which are related to metabolic syndrome. Now, my problem, why I started looking into these factors was, you know, my case. My CT, my carotid was normal, my TRAP enzymes were normal, everything was coming normal, but only CT angio showed. And that also my persistence, because my symptoms were also atypical. That was one of the reasons I'm working on this because I have seen colleagues who were asymptomatic, who had everything normal, even lipid profile normal. I had just borderline triglycerides, upper limit, not even raised or anything. And they were put on HRT and they had MRI. So we are missing out into some factors which are very, very important for the midlife clinics or the menopausal ladies, where we have to decide they need the HRT, whether we can give them or not give them. So that is one of the reasons where we will be collecting this data, and I think we will be coming out with the more. Dr. Rakesh Gupta, are you there? Yes, left. Dr. Rakesh?
He's there,
Yeah,
ma'am.
hello. I'm here.
Yeah, Dr. Rakesh and Dr. Bansal. Two things very important which you have mentioned is the risk calculating charts. Of you gave about the diabetes, you gave about the, that should be on the table of each and every practitioner, whether FOGS members or the IMA members. Can you make them available? At least we can create that awareness.
It's very simple chart. It's not very difficult.
That's very simple. That's why I say it's a simple thing, minimum thing. Why are we not making it available?
The chart can be made very easily available to everyone around us.
Yes.
So I can share it with you. And second thing, you were talking about the BMI, that we should have some chart.
Yeah. So we are coming together. So what I am suggesting is these things minimum should be there on everybody's. Your risk chart. This is the BMI calculating this, which I introduced to FOGSI about 10 years back. So I made the pharma companies tell them you don't give them any gifts, but give these gifts to the doctors so that they can have. My staff, they record their blood pressure, their waist circumference, weight and height, calculate their BMI from these charts or these charts, and then the patient comes to me. Can that be done with all the practitioners? Simple.
Yeah, in my OPD, these things are done practically for every patient.
You are a physician, you are a diabetologist, you are sitting in a hospital. Dr. Rakesh, I am talking about those physicians who are not doing, who are at the periphery and who are getting the maximum number of patients where we can prevent.
Yes, sure.
So that is what I want. I think we are getting delayed. Any chairpersons have to make any report because Dr.
Dr. Bansal has highlighted the importance of smoking cessation. So I was reading somewhere when the patient, the concerned, the index patient stops smoking, for next 10 years, he is more likely to develop metabolic syndrome because it causes, gradual weight gain once he or she starts smoking, especially the risk is more if she's smoking more than 40 cigarettes in a day or he's smoking more than, and the risk lasts for 10 years if he or she is smoking 20 cigarettes. So I think Dr. Piyush Ranjan will be dealing with the weight control and all, and I will request him to make a comment about this also. So I'll request ma'am to introduce Dr. Piyush Ranjan for his next presentation.
Yes, we are getting delayed. The only slide which I have to show now is add life to years and not just years to life. And all the three speakers, they have been excellent, far excellent. Dr. NK Pandey, who took us through a journey of pills which can delay or give us healthy aging or going to the space. Dr. Rakesh Gupta was really super excellent, going into the journey of diabetes and how we can be prevented at each and every stage. So I'm requesting them, please make these charts available. And same way, Dr. S.S. Bansal, he has clarified so many things which even I didn't know about the statins and aspirins and everything. But I think all the three speakers of you should come to more of these forums, and at least Faridabad practitioners should be educated enough to prevent these diseases in the early stages. So coming together is beginning, keeping together is progress, and working together is success. So I expect with all of you to work together in the future years so that we can have at least the focus on Faridabad population itself. Thank you very much for being there. Now, Dr.
Piyush. I'm really thankful to Dr. Piyush for being so patient. I'll request Rubina ma'am to kindly introduce Dr. Piyush Ranjan. Can I have
Yeah,
CV,
thank you very
Deepika?
much. Can I have my
There's
slide?
not much CV actually. So he is just the additional professor in the Department of Medicine in All India Institute of Medical Sciences. Rubina, I'm sorry because you would not have been able to see it. So that's why.
No, it's perfectly okay. Actually, this is a very important topic, and I think talking about the integrated management approach for midlife is an extremely important area, and we are all eagerly waiting to hear what Dr. Piyush has to tell us. So without any further ado, I will hand over the mic to Dr. Piyush.
Yeah, just one thing more, that Dr. Piyush was the one who had developed the guidelines for weight management, and there were extensive sessions, and we were one of those authors also in that. So that's why he's an expert now, because he has developed the guidelines on how to do integrated approach for weight management. Dr. Piyush,
Maninder, I would suggest that if you could take his presentation at the end and share it with the group, because this is
I'm not
something
taking any presentation, Rubina. I stopped sharing. I'm not taking any. I'm finished.
Yeah.
Okay. Am I audible?
Yes, yes, Piyush.
Thank you very much, and thank you very much, lovely audience and lovely, very knowledgeable panelist, I would say, and especially I am overwhelmed with the knowledge of Dr. Bansal. He has read out the whole Harrison Brownwell chapter for us in just 1 hour. So thank you very much, and without much introduction. So all of the previous speakers, they have talked about it is important to lose weight. Ma'am Ahuja has talked about the BMI should be with everyone. BMI calculator should be with everyone. And the main problem is how to change behavior of the person. The real doctor's dilemma is that our patient would listen more to the Babaji or film actresses, but not to the prescription that we would be giving. So anyway, the whole approach, or the another 40 minutes which I have prepared with my team, I will cut short to 20 minutes at least, so that we can give the real pearls for the practice, so that we can really help our patients, motivating them to remain stick to the healthy lifestyle. And this is the team. It consists of the exercise expert, the yoga experts, psychologists. They all have done masters in their respective field, and they are doing PhD with me. And we have recently done a number of original studies, and our suggestion in the related this field is based on our own experience with this. So the introduction for this, we all know that almost 1 in 4 adults are overweight. This is the recent data that says that 1/3 of the patient, all individual in the midlife age are actually obese. Obesity has got several implications, and the real problem is that about 20% of the total obese patient that we are seeing who have enrolled themselves to the weight management have actually about 80% of them have failed mercilessly. And the more our challenge is to improve compliance in the midlife age group, because many of them, we find them, there is lack of motivation, there are other associated illnesses and the social factors that are there. So I would talk about some of the recent studies that we have done that has increased our insight in this. So the first was the focus group discussion with the perimenopausal women, and in which we have talked about what risk factors and what are the other factors that act as the barriers and facilitators in the midlife age group women. This was well taken, and it was published in the menopause, the journals of the North America. And with the Journal of Midlife Health, we have published the comprehensive evaluation tool. The Madam Ahuja was talking about the tool that should remain with all midlife care physician. So this was the tool that used to evaluate, that was capable in evaluating the overall comprehensive risk factors, barriers, and facilitators for for all those who are at the risk of obesity. So this is freely available, and I hope under the guidance of Dr. Ahuja, Madam, this could reach to the all necessary all physicians. So these are some of the guidelines which we have published, and we would be talking more about that. So as we all know that the weight management consists of the dietary approach, the exercise approach, the psychological intervention that can improve the compliance, as well as the other factor the speakers were talking about, the stress level, the sleep and other things. And that's why we need the integrated approach for the weight management. And as we have discussed, probably the midlife clinic could be the torchbearer in this. So with this background, I would like to call my first speaker, who would be talking about the dietary prescription, how to give the dietary prescription to our participants so that they can be, so that the overall compliance and other things can be increased. So Sakshi Chopra, she is PhD scholar and she is doing PhD with us, and she is trained dietitian. So over to you, Sakshi.
Good evening, everybody. So we'll be talking about the principles of dietary advices for weight management. We basically need to reduce the caloric intake from the current caloric intake of for about 500 to 750 kilocalories to reduce half a kg body weight per week. Now, we have seen that in clinical practices, low calorie diets range from 1500 to 1800 kilocal for men and 1000 to 1200 kilocal for women. The practitioner should also note that these diets should be customized according to the eating and cultural preferences of the patients, and these should be balanced in the macro and the micronutrients. When we talk about the translation of the calories to macronutrients, the first one is the carbohydrate, as it is slightly more than 50% of the calories are from carbohydrates. Basically, the practitioner should advise complex carbohydrates over simple carbohydrates, which would include whole wheat flour, oats, fruits, and vegetables. Around 1/4 of the diet, the calorie will be from low-fat protein sources. The caution should be that it should be from low-fat protein sources and not from high-fat protein sources. And it should be from low-fat milk, legumes, nuts, oilseeds, and lean meat pieces like fish and chicken. 30% of the total caloric intake should be from a combination of oils, nuts, and oil seeds. The patient should be advised to reduce the intake of industrially produced trans fats, which is basically in processed products like chips, biscuits, cookies, etc. And also from saturated fats. These are the fats that solidify at room temperature, like margarine, dalda, ghee, butter, etc. If adequately balanced with the fruits and vegetable intake, whole grain, legumes, and nuts and oilseeds, the practitioner should try to target a total fiber intake of 30 grams per day as well. Some of the noteworthy micronutrients in that should be taken care of are sodium, iron, and calcium. A limited intake of, say, 1 teaspoon of iodized salt should be targeted, and special attention should be given to iron and calcium intake as well for better overall health. Now, since we have just talked about calories and macronutrients, that seems a bit too technical and scientific in nature, but this will act as a visual, practical eat well plate, which will be a visual guide to the patient. And if you can see on your screens, almost 1/3 of your plate should be from complex carbohydrates. So, and 1/3 should be from fruits and vegetables, which will provide the soluble and insoluble fiber. And then 1/3 should be from vegetarian and non-vegetarian sources of protein. So this can be used by the clinicians to guide their patients on how to, counsel them in a very practical format to eat healthier. We have also seen that most of the patients will do the diet properly from in their major meals, but generally deviate in while snacking in between the meals. The rule of thumb is that they should be motivated to eat they should be motivated to eat healthier versions of things that are already, high in fat, salt, and sugar. For example, if they're craving a chocolate pastry, they should be motivated to eat a dark chocolate instead, which is lesser in calories. And the dietary advices should also be backed up by better eating behavior, reinforcing a better eating behavior. So, having small and frequent meals, that should be advised. These meals should be pre-planned, because a 5-meal pattern should be devised where 3 major meals are there and 2 snacks are there. We have also seen patients who are eating from smaller plates and bowls are able to reduce their caloric intake better. And the practitioner should also recommend low-fat cooking methods like steaming, boiling, sauteing, etc. Also recommend switching to healthier ingredients. So, for example, your patient wants to eat a sandwich with a mayonnaise spread. Rather than that, you should advise a hung curd dressing, and also motivate them to eat in a environment which is not deviated with the television, Netflix, and everything. And they should be the meal time should at least be 15 minutes where they're properly engaging with the food and chewing properly. Now, this was about eating when they're at home. When they are socializing and eating out, they should be able to read the menu. So empower the patient to read the menu. Motivate them to customize their meals properly. Ask them to order an appetizer as a main dish itself, so it reduces the total caloric intake. Opt for high protein dishes like based from chicken, pulses, egg, dairy, and fish, and try to avoid sugar sweetened beverages and dessert in total.
So so these are the important things. So it is very difficult for all clinicians to have a dietitian, dedicated dietitian with them. So if we summarize, you can ask your patients, just avoid food in between meals. As I was listening to one of the speakers, he was saying that we are inherent. Dr. Gupta was saying that कि हमारे यहाँ कुछ भी होता है पहले खिला करके, खाते समय जन्म से लेकर के मृत्यु तक हमेशा खिलाना. So probably we need a change in the overall mentality. What we can say कि घी, तेल, मीठा, मसाला. So कुछ भी फ्राइड चीज उसे अवॉइड करो. कोई भी चीज जो कि मीठा, खाने में मीठा लगे, even the sweet fruits like mango, lychee and other things, मीठा and मसाला, जो भी जैसे फ्राइड चिकन, फ्राइड इसके बदले जो कोई भी अभी हैव टोल्ड कि वाइल्ड चिकन एंड द जो हॉट एयर में या ओवन से हम लोग ये खा सकते हैं. And no food in between meals, and there are always healthier options. So with this thing, with these practical tips that you can give to your patient so that they can stick to the prescription or healthy diet. What is important that most of our patients, they make nonsense of the dietitian's practices. उनको ये छोटी छोटी बातें अगर बताएं, which we have found with our patients, जो कि in all the published data which I am unable to show because of paucity of time. So with this, I invite another speaker who is also a PhD scholar, and she would be talking about all those forms of physical activity and exercise that our patients who need weight management will require, and how to do that, and what are the practical tips that can be given to them. Now I invite Varisha Anwar.
Good evening, everybody. I'll be talking about midlife weight management through physical activity. So firstly, I'll tell you about what is physical activity and what is exercise. Physical activity encompasses all bodily movements that are carried out by muscles and requires energy, whereas exercise is a type of physical activity that requires planned, repetitive, intentional, and structured movement over a period of time. As we all know, there are various benefits of physical activity and exercise. It helps in weight management by increasing BMR and better cardiometabolic health, respiratory fitness, muscular strength, endurance, and of course, decreased risk of osteoporosis. Now, there are various types of physical exercise. First one is endurance. This includes aerobic activities, which basically helps in improving our cardiorespiratory fitness. Then there are strength activities, which includes activities with dumbbells, bands, etc., which helps in building strength, power, hypertrophy, and endurance. Then there are flexibility activities, which helps in facilitating joint movements and prevents tissue damage. while specific to each joint and helping in stretching the muscles. Lastly, balance activities, which are often ignored, are known to help in reducing the risk of falls, improves motor skills, and provides stability in joints, thus preventing injuries and sprain. We encounter various challenges in improving physical inactivity, and these are interpersonal barriers, organizational and policy-related barriers, and intrapersonal barriers and environmental barriers. Among these, in the interpersonal barriers, we encounter fatigue, sleep deprivation, lack of time, resources, stress and anxiety, injury or ailment, and for the menopausal women, there are vasomotor symptoms and health conditions like osteoporosis, sarcopenia, and lack of motivation, preparedness. Then there are interpersonal barriers such as socio-familial support, household chores, accountability, childcare, and other environmental barriers, and organizational and policy-related barriers. Physical activities can be performed at varied intensities. In light intensity, the breathing remains normal with no change. This includes the classical example of slow walking at home or workplace, light housework, flexibility exercises, and light yoga. Another one is moderate intensity, where the breathing quickens. A person can hold conversation but cannot sing. The classical examples are walking at a brisk pace, bike riding at a faster pace, or uphill, heavy cleaning, dancing, and standard yoga. And in the vigorous intensity, breathing becomes rapid. You can't say more than few words. And in that, the classical examples are fast-paced walking, running or jogging, hiking, swimming, carrying heavy loads, and heavy farming, shoveling, and digging. Now, coming to the physical activity prescription for the midlife, here the frequency should be more than 5 days in a week to maximize our calorie expenditure, and the intensity should be moderate to vigorous, and timing should be 30 to 60 minutes per day, accumulating to 150 to 300 minutes of moderate intensity activity per week, or 75 to 150 minutes of vigorous intensity activity per week. The examples are aerobic activities, including large muscle groups, at least 30 minutes 5 days in a week, resistance training using weight and bands, calisthenics at least one set of all major muscle groups twice a week, flexibility 2 days a week, and balance training at least once a week. The balance training helps in reducing the risk of falls.
So we have seen that before we are prescribing any exercise prescription to our patient, it is important to look at the barriers. So if someone who is having, say, joint pain, we cannot ask him bluntly that he can do for 30 minutes jogging, or we can give the same prescription to all patients. This is number one. While giving any prescription, we should definitely look at the societal barriers. That particular person might not be having the playground or other ground where he can do the jogging and other things. This is number one. Number two, our prescription should have all the mixture of all 4 types of exercises. And the rule of thumb is everyone should be engaged in moderate intensity physical exercise at least 30 minutes a day, 5 days a week. And apart from that, to combat with the sarcopenia, one should definitely be doing the strength exercise and the other form of exercise, especially the balance exercise. It is also important nowadays. We are seeing that the yoga that has been with us since our ancient time is being strongly advocated, and we have seen in our many projects and our experience with the many of the patients that yoga is better not only as a moderate intensity physical exercise, but it has got a better impact on the overall well-being. So with this, I invite Mr. Anand Gopal. He is PhD scholar and he has done his masters in yoga, and he would be talking about what are the yoga exercises that is useful for our patients, especially in the mid-age who needs weight management. Mr. Anand Gopal.
Very good evening, everyone. Thank you so much for introducing and sharing the effectiveness of yoga with respect to midlife weight management. So I will be highlighting various dimensions of yoga, which constitutes yoga therapy, which includes breathing exercises, loosening exercises, asanas, pranayama, meditation, and relaxations. All those comes together and defines yoga therapies. So yoga therapy is where yogic practices are modified based on the based on the requirement and use of considering the effectiveness and safety purpose. So that the obese patients, those who are undertaking these practices, can practice properly. So these are the few breathing exercises which we perform in standing, sitting, supine, and prone. So in the first practice, you can see hands in and out breathing. So mainly we try to draw their attention to their breath, body, and mind. So while practicing hands in and out breathing, we instruct our patients to bring both the palms together in front of our chest, and while inhaling, they expand and take both the hands back. And with the exhalation, they slowly and gently bring both the hands front. So this is how they practice for 5 to 7 rounds. And in the second picture, as you can see, Bhujangasana, we instruct our patients to come on the mat and lie in prone position. With the inhalation, they raise the chest up and they look up. With the exhalation, they come down. So this is how repeatedly they practice for 5 to 7 rounds, which gives a nice stretch and improves their flexibility to their spine and reduces the abdominal fat. And in the third picture, as you can see, Shalvasana breathing. So with keeping limitation in the mind, we instruct our patients to practice with the inhalation to raise both the heels up, both the legs up. With the exhalation, they bring it down. And in the fourth picture, as you can see, they're performing straight leg rise breathing with the inhalation, with the exhalation, they raise their alternate legs, which helps in reducing the abdominal fat and improves the flexibility to their thigh region. So there are also a number of breathing exercises, and I'll be also talking about loosening exercises, which helps in warming and loosening before performing any asanas. In the first picture, as you can see, butterfly, which helps in improving the flexibility to the thigh region, and also directly it helps in the reduction of fat in the thigh region, and also aligns the spine, which helps in reducing the back pain, neck pain, and also knee pain, and also strengthens the muscles. Particular muscles are engaged with those areas. In the second practice, cycling, we perform with the normal breathing, clockwise and anti-clockwise, which strengthens the knee muscles and also helps in reducing abdominal fat, lower abdominal fat. And the third practice is knee loosening, which helps in strengthening the knee muscles. So these are also a few other loosening practices for overall body loosening. First one is jogging with normal breathing, the warm up, and second one is spinal twist. Also gives a which improves the spinal flexibility and also improves in reducing excess accumulation of fat in the lateral part of the body and also in the central abdomen. And the third one is side bending. It also improves the spinal flexibility and helps in reducing the fat. And these are the few postures. A few asanas are the static posture where we instruct and ask them to maintain for a while, which helps in improving the endurance and also improve the flexibility with reducing the muscle rigidity and improves muscle flexibility and directly helps in reducing the fat. In standing, there are a number of practices. I've displayed one practice, which is revolving triangle posture, which is known as Parivritta Trikona Asana. And second one is Vakra Asana. The third one is Dhanurasana, and fourth one is Navasana. And all those practices are modified as and when it is required based on the requirement of the patients. And pranayama techniques, which directly helps in reducing the which helps in weight loss. The right nostril breathing, which is also known as Surya Anulom Vilom, that helps in reducing the weight. And second one is Chandra Anulom Vilom. It is considered one of the cooling pranayama, which brings balance between both the nostril. And the third one is Nadi Shuddhi pranayama, which is also known as Anuloma Viloma, which is combination of Surya Anulom Vilom and Chandra Anulom Vilom, brings balance between autonomic nervous system and gives rise to parasympathetic activity and brings balance, and in turn which reduces depression, anxiety, and stress. Meditation technique, where we instruct them to, which is guided instruction, and we ask them to mindfully concentrate on particular object, and then gradually when they progress in the practice, we ask them to focus internally, then slowly and gradually they increase their duration, then which leads to mental relaxation and reduces the depression and anxiety and also improves sleep pattern. And then finally, we ask them to observe silence and go to the next step called resolve, where they take a resolve for practicing regularly and to reduce the compliance. And at the end, we instruct them to go for the relaxation, which is most required for the muscle relaxation. So it may be instant relaxation within 1 minute, quick relaxation with the break for 3 minutes, or each particular part means, it will be guided for 8 to 10 minutes for entire whole body relaxation. Then for all the practitioners, we prescribe duration of the practices. Normally we ask them to practice for 1 hour, which constitutes 40 minutes of practice, breathing, listening, and asanas, 5 minutes of pranayama, 5 minutes of meditation, and 10 minutes of relaxation technique is most required. Initially they can start with 30 to 40 minutes of practice, then slowly and gradually they can progress their practice up to 60 minutes, and minimum we instruct them to practice for 5 days in a week.
Thank you very much, Anand, for the yoga prescription that is there. So I know it is very difficult in 5 to 10 minutes for everyone to understand and prescribe it to their patients. So what is important to understand? There are certain important key points. First is that the different type of asana and the time, they have been scientifically tested, and in association with the leading yoga institution, Morarji Desai Institute of Yoga and Naturopathy, we have developed it, validated it, and we have conducted several experiments. So you can take aims for sure that this is going to work. Number one. Number two, initially yoga has got definitely the effect on the body fat and on the other aspects also. It reduces the sympathetic nervous system, sympathetic burst, and the stress, and someone was talking about sleep and other thing. So it has got the holistic effect on the different components of our lifestyle. And what is more important, that if it is followed under supervision at least, then this is going to help. So with this, we are quickly winding up, and now I would call my fourth and the final speaker on this, how to address the various psychological conflicts and how to do the behavioral counseling. We have seen that whether cognitive behavioral therapy, is it the missing link in the management of obesity? So what we are seeing that everybody knows कि खाना कम खाओ, खूब दौड़ो, अच्छे से रहो, मोटे नहीं हो, लेकिन कितने % लोग ऐसा कर पाते हैं? 10 to 15%, और हमारे कहे पर तो उससे भी कम आते हैं. वो 10 to 15% वो लोग होते हैं who have to get themselves fit in their lehenga, in their wedding dress, और वो भी they are sort of they have other motivations, और किसी ने बाबा जी ने कह दिया या किसी फिल्म एक्ट्रेस ने कह दिया. So this is the time for them to get motivated by the real cause. And how can we help them? How can we improve their compliance? This would be talked by the Tanveer Kaur, who has done her master's in psychology, and she is doing PhD with us. So over to you, Tanveer.
Thank you, sir. Good evening, everyone. Today I'll be talking about the behavioral counseling for the weight management. Some of the points that I'll be covering are biopsychosocial factors, initiation of weight management, assessment of behavioral and psychological barriers, and incorporating the behavioral techniques. So in the first line of the management of obesity, often the challenges such the various factors such as the psychological, cognitive, and situational barriers often go unidentified and unaddressed. So the behavioral change is even more difficult in the midlife due to several biopsychosocial factors. Some of the factors such as emotional eating, stress, depression, genetics, metabolism, comorbidities, food policy, or geographical areas are some of the factors which actually determine the obesity in an individual. So we'll be discussing about a stepwise approach on how to motivate, psychoeducate, identify the underlying biological and behavioral causes, and how to develop a therapeutic alliance with the patient. So the very first step is the initiation of weight management advice. Due to the excessive weight, these obese individuals are often discriminated and stigmatized by their own family members, friends, and societies. And because of this stigmatization, they often develop some sort of psychological issues such as body image issues or low self-esteem, which often so they basically start lacking the motivation in compliance to the entire obesity or the weight management treatment. So to avoid the discrimination, a clinician should be very empathetic and non-judgmental, should understand that obesity is a complex disease, and a very healthy and a positive relationship should be developed with the patient. Secondly, it is the clinician's role to make individual aware about the obesity and the associated comorbidities, encourage them to have a healthy lifestyle, and help them to overcome any reluctance in undergoing the lifestyle changes. Once the patients are open to considering this line of treatment, the next step is to assess the psychological and the behavioral treatment. So some of the steps that we need to make sure that some of the steps that we need to follow are that in the regular clinical assessment, screening of the psychological issues such as depression, anxiety, stress should be made. Clinicians should try to understand the previous weight loss attempts, because the previous attempts actually shape the attitude and the belief of an individual. Weight loss goals and expectations should be there. A realistic goal should be set, because unrealistic goal would lead to negative impact. Then personal attributes such as stressors or emotional eating should be identified. And finally, the social and the environmental cues such as obesogenic environment, lack of social support, and sedentary lifestyle should also be identified during the process. After the analysis of these psychological and the behavioral component, the next step is enrollment in the treatment program. So some of the behavioral components that we can incorporate are goal setting. For example, setting a goal of only loss of 0.5 kg weight every week, stimulus control like deleting all the food ordering applications from the mobile, problem solving, portion control while eating out at any festivities, the reinforcement where clinician can actually encourage them to have a cheat day once in a week, and self-monitoring techniques such as maintaining a journal about the food intake and the activity routine. So these components can be used along with the regular treatment to promote the behavioral change in the long run. Once the clinician feels that the goals are achieved, and the entire program can be terminated only after discussing with the patient and with the mutual consent of the patient. So lastly, the problem of relapse prevention relapse should be addressed during the termination. Self-monitoring techniques can be taught to help them to keep a check on their progress, and positive and negative reinforcement can be used according to whether the person was able to comply to the entire treatment plan or not. Lastly, a regular follow-up session should be encouraged to keep a check on the entire progress of the patient.
So these are just some of the important things that we can actually incorporate in our advices so that our prescriptions are honored more and better than any other Babaji or any other film actor or actresses. So this is just a glimpse of the things that we can do. And I would advise, I know it is very difficult to remember each and everything, but these are the part of the published articles. And this is the 4 articles which I would encourage all participants and practitioners in the weight management practice to read this. These are the 4 important articles in this. First is the stepwise approach to prescribe dietary and weight management program, which is again by our team. And the second one is the physical activity, yoga and exercise practices for midlife as well as postpartum. So this is again published in the Jogi, and in which we have incorporated all the changes on all the exercise that a physician should know. And the third one is the counseling and behavioral modification techniques. So in which we have discussed each and every point in detail, which Tanveer has given just a glimpse of all this. So this is the evidence-based summary, in which many of us, especially Dr. Maninder Ahuja madam, was a part of that weight clinical practice guideline team, and this was AIMS DST initiative. And with this, considering the paucity of time, I apologize because I have to rush through the slides. But just to give you a point to ponder with and just keep the ball rolling. And we definitely, it's a huge problem, and the solution cannot be created in one day. But with each step, with the first step, wise people have said the first step is very important, because the half work is done when we take the first mighty and big step. So with this, I thank all the participants. I can see there are still more than 3 dozen participants. They are still there. They have skipped their dinner time, meal time. And thank you very much to all the panelists. The senior people are there, and they have given our team an opportunity. And with this, I conclude my today's discussion, and open to any question and discussion if they want. Thank you very much, Dr. Ahuja, for giving us the time.
Dr. Piyush, I had put an inquiry that after smoking cessation, the patient is likely to gain weight, especially if he or she has been a heavy smoker. So your comments about it. So we need to prescribe, along with the cigarette smoking cessation, they should have some weight management strategies. Otherwise, the benefits of cessation of smoking gets neutralized by weight gain. So what are your comments about this?
Ma'am, smoking is definitely one of the worst things that anyone can do. So whether that was the weight gain, or whether that was the paucity in the weight loss, that was otherwise because of that. So this is one thing, is that, so reason for cessation of smoking is not just for the weight appropriation. And to the best of my knowledge, that nicotine is not something that actually can be used as a drug for body weight reduction. So weight gain or gaining the weight abnormal reduction in the body weight loss, that can be because of the overall change in the psyche of the person. So yes, weight appropriation and management is there, and I totally agree with you that when someone has successfully completed the smoking cessation program, then he should be definitely side by side introduced about the other aspects of the healthy lifestyle, which includes balanced diet, regular exercise, and the other things like sleep and other behavioral stress reduction and other.
Thank you, sir. Rubina ma'am.
I think it was an excellent presentation, and basically they've covered all aspects of weight management. So I congratulate the speakers on that. Thank you very much.
Thank you. Maninder ma'am, your comments. Divya has been keeping silent all over. I invite her comments also.
Divya had to leave, I think. Okay. And Zinnat is here, or she has left?
No, I am here.
Yeah, Zinnat ma'am.
Well,
so
actually,
I think this has been a wonderful session, and this is the first time Dr. Deepika can vouch for me that we are never late in our webinars. But this was the one session where everybody was giving such an excellent presentation that I didn't have the heart to tell them to cut down or anything. So I'm sorry for the delay, but I think it was worth it. Do you agree, Zinnat, it was worth it?
Yes, definitely. I really enjoyed.
Ma'am, you had so many comments on Facebook itself. As soon as the webinar started, so many comments are pouring in on Facebook also.
I checked up, even the Facebook is going live. So people are there even at this time. So that was worth it. Dr. Piyush, it was an excellent presentation.
Yes.
The only thing which I can add on now is that we will have a repeat, just the exercise and the nutrition part of it. Just that webinar only. I think next month, let's have again this one, because this is the message which has to go in a right way. And I liked, I have been, I'm very particular about resistance and weight training. The first time I started liking idea of yoga exercises, because yoga exercises as such are more acceptable to people. And weight training, they will always avoid it unless when it was integrated into our lifestyle, like everything, doing exercises at the home. So now the people avoid doing that, but yoga, everybody is happy. And I think, Piyush, we should do some project on yoga exercises again, whether they can increase BMD or not. That is my question. Because BMD is the only part where we will need some sort of resistance training at least twice in a week to be added. Otherwise, 5 days in a week, a simple aerobic and yoga exercises can be done.
Usually, I want you to highlight in 2 lines about kinesthetic exercises. I think audience wants to hear about that.
Yes, ma'am. So before that, I will address Madam Maninder, my Ahuja's suggestion. Ma'am, we have recently completed our project on yoga and obesity, in which yoga was converted in a randomized control trial. We have compared yoga with moderate intensity physical exercise among obese patient. Another was among NFLD patient, and the third one was in the sarcopenic patient and the patient who are having osteoporosis also. So these 2 projects are being supported by ICMR, one by ICMR, another one is by DHR, which we are continuing. So the result will be shared in some forum, one forum or another. And before I would ask Varisha to address the question on that. So I share the all credit with my team member. So they are a PhD scholar, they are the wonderful people, and they are backbone of our research activity which we are doing in a clinical institute.
Body's weight against the floor or any other surface to actually work out. So that will include activities such as push-ups, pull-ups, or it could be squats, lunges. All of these includes calisthenics. So calisthenics is not anything which is very athletic. It is the very basic exercises which are actually the foundation of following activities. So that is calisthenics.
Thank you. Thank you.
Squats and lunges are my favorite. If you have to avoid knee replacement, please go on doing them. Anytime. You can do these studies also because they do build up cartilage thickness also, knee cartilage if you are doing squats and lunges. So these are the easier one to be done because they don't need any weights. So body weight they can be done, and each and every one of us, even we can do when in the clinics we don't have patients. Just doing 10 squats or some 10 lunges is very, very easy. But the way we are standing during our operations and all that, we are carrying the weight on our knees in a very bad way, not the aligned way. So that hurts our knees. So those especially surgeons and physicians who are standing, even ultrasonologists who are standing doing these things, or clinicians also, in between, if they do these stretching exercises and squats and lunges, I think that's going to help them a lot. Do you accept this is agree to it? Sakshi and who is the ex? Varisha.
Yes, ma'am, I agree.
Piyush, they are actually sitting like your backbone only. To me, they look like your backbone.
Exactly.
You are lucky to have them.
Yes, the whole team, ma'am, they should be congratulated.
Yeah.
And Piyush sir, one important thing you highlighted is that comorbidities have to be addressed before advising exercise to patients. The exercise should be appropriate for that particular body habitus, age, and comorbidities. Thank you for that. I think Deepika.
Deepika, can you take a group picture of Dr. Piyush Ranjan with their team? Just take it. I love it the way I'm seeing it, looking at it. And Piyush, I'm going to repeat this webinar, especially your part only again. We'll do in different,
Forums, yeah.
Different forums we'll be doing. And I think it's time to say thank you to Jagsonpal for being our technical partners, to all the panelists and all the faculty who have been really wonderful, starting from Dr. Pandey to Dr. Rakesh Gupta and Dr. SS Bansal, but more so our guests of honor and chief guest, Dr. Hrishikesh Pai, Dr. Asmita, and Dr. Shahnazan or Sahajanand Singh, who is the IMA president, and all the wonderful chairpersons. I just don't have words enough to thank Dr. Rubina Sohail, Dr. Zinnat, and Dr. Anita Razoria for being here. Dr. Punita Hasija, She has been my right hand from the very beginning when I started working, and she has done really wonders. That's why she has risen to the post of Haryana IMA, and I wish her more better future prospects also. Thank you, all of you.
Dr. Sudha Sharma.
Yeah, she left, so that's why I was seeing I'm missing somebody. Dr. Sudha Sharma, who was here, and despite some function, I mean, there was not very pleasant event in family death. She just stayed on there to give her comments. So I'm thankful to her also and to all. And then Deepika, to you for being our backbone.
Yes.
Thank you for being
Thank
staying.
you, everyone. Thank you, ma'am, for giving us this opportunity. Thank you. Thank you so much.
Thank you.
Thank you. I take this opportunity and just remind you of LycoRed, the ultimate cell protector. Whenever oxidative stress threatens or metabolic syndrome, LycoRed Softgels are available. Other products of Jagsonpal are Doxypal DRL, 100 mg capsules of doxycycline with lactic acid bacillus, and Cystilia M, which is myo-inositol and D-chiroinositol with L-methyl folate and vitamin D3. Thank you very much, and we hope to see you again on 7th June when we have the next in the series, which is research methodology organized by Journal Committee of Midlife Health and Sir Gangaram Hospital with SMLM again. Please note down the webinar ID and join us again.